Good morning, everyone. Welcome to this two-day event. Welcome to the fourth postgraduate course of the Department of Emergency Medicine, Southern Philippines Medical Center. Embrace the odds, the old, the new, and the new normal. As we start this event, may we all remain in solemnity for the invocation and for the national anthem.
بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. In the name of Allah, most gracious, most merciful. All praise is due to Allah, the Lord of the worlds, the most compassionate, the most merciful, Master of the day of judgment. You alone we worship, and you alone we ask for help. Guide us to the straight path, the path of those you have blessed, not of those who have incurred your wrath, nor of those who have gone astray. بسم الله الرحمن الرحيم قل الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. In the name of Allah, the merciful, the compassionate, say, He is Allah, the one and unique. Allah, who is in need of none, and of whom all are in need. He neither begot any, nor was he begotten, and none is comparable to him. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. Our Lord, give us in this world that which is good, and the hereafter which is good, and save us from the torment of the fire. Walhamdulillah Rabbil Alameen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang magiliw, helas ng sinakanan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, tuyag ka ng magiting, sa manlulupin, di ka pasisingil, sa nagagang tutok sa simoy at sa langit mong pagaw, ay hinatang tulang awit sa pagkayang minamahal. Ang isang ng matawad mo'y tagumpay na nagtitindig, ang bituin at araw niya kailan ang ay magtitindig. Luman ang araw ng walhaging pagsinta, buhay langit sa piling mo. Ang inigaya ng pagkay mga amin, ang mamatay ng dahil sa'yo.
Good day! Welcome to the Southern Philippines Medical Center, Department of Emergency Medicine 4th Postgraduate Course. To ensure a productive experience in the entire webinar, please observe the following. Check your internet speed. For optimal audio and video experience, use of headphones is highly recommended. In accordance to the Data Privacy Act, video recording of lectures is strictly prohibited. Attendees may type their questions at the Q&A button, which will be addressed at the end of the lectures. Certificate of attendance will only be emailed to those who submitted the evaluation form. An evaluation form link will be posted on the last day of the webinar. Thank you and enjoy!
There will be a raffle draw for this postgraduate course at the end of the last lecture. For today, that would be at the end of this afternoon session, and tomorrow at the end of the morning session. 3 winners will be randomly generated via an electronic draw, and each winner will receive 1,000 pesos each. And to officially welcome us all in this two-day event, let us hear from the ever-dynamic chairman of the Department of Emergency Medicine, Southern Philippines Medical Center, Dr. Benedict Edward P. Valdez.
Good morning to all the participants of this conference. Welcome to Southern Philippines Medical Center postgraduate course entitled Embrace the Odds, the Old, the New, and the New Normal. We have invited best speakers who will share their expertise on specific topics. Your participation means a lot to us, and we are equally excited to be part of your successful journey as clinical practitioners. We do offer topics that can help anyone in the strife of pandemic, and your time and presence means a lot to us. So we see to it that it will be a very good learning and interactive experience for all of us. Spmc Emed is a trendsetter in the practice of hyperbaric, difficult wound and diving medicine in the Philippines today. We share our experiences in this forum, and there are topics on disaster COVID-related management, financial management, financial risk protection, simulation medicine, and palliative care are among the impressive and interesting topics that we can learn from. As one among the youngest department in the hospital and in the Philippines, we created a training program that would address the needs of the populace, both clinical and in public health. Having this postgraduate course hits 2 important objectives. One, that Emed is an important specialty, and 2, our research and practices will speak for us. Without much further talk, I welcome you all to this conference with a steadfast and fruitful day ahead. Good morning to everyone.
Our first speaker is a Doctor of Medicine obtained at the University of the East Ramon Magsaysay Memorial Medical Center. She had her master's in public health at the University of the Philippines. She had her diploma in human resource development at Ateneo de Manila University. She is a resource speaker and a training consultant of various training programs. She is an author of various papers and reports in NEDA, WHO, and Inter-LGUs. To talk about pandemic-ready PhilHealth and its strategies in COVID times, everybody, let us all welcome Dr. Shirley Lourdes Antonia Domingo.
Good day, everyone. And I would like to thank the organizers of this convention for inviting us. PhilHealth always finds it a good opportunity to discuss its work and its program to all its stakeholders. I like the theme of this convention, embracing the odds, the old, the new, and the normal. Odds. What is odds? The probability that one thing will happen rather than another. Actually, we're in a very unfamiliar territory here. We are operating in a scenario by which we follow existing policies and rules, but the enemy, the virus, keeps on changing and introducing new war fronts. Therefore, the odds of success changes by the day until we find that new normal and sustain the gains we have achieved so far. So how do we find that new normal in health? PhilHealth is the financing arm of the health sector. Therefore, to plan and implement strategies, it takes its cue from the givens of the health sector. What are the parameters by which we implement strategies under the current pandemic? Will our health system revert back to what we knew it before? Will we have to reinvent new rules for an entirely new health system after this pandemic? New realities? Well, there are certain parameters that we have to plan our strategies on. One of the cues is that age-old issues like TB, malaria, and re-emerging and lifestyle diseases may and are still causing debility. Diseases that can be prevented but is taking its toll in our health system. If there is one thing that was clearly demonstrated in this pandemic, it is that strengthening our immune system to fight diseases is a responsibility not only to ourselves but for the good of the community. We have to channel more efforts and a lot more resources into primary health care. What we learned also in this pandemic, it was really a good lesson to learn. Government cannot do it alone. Each challenge has to be faced together as a whole nation. We have to form partnerships, networks, and strengthen our health system by these linkages. The goal of a fully vaccinated nation acquiring herd immunity against COVID can only be achieved because the private sector is now funding and implementing their own vaccination activities in consonance with RA 11525 or the National Vaccination Program of the Philippines. So what will be the next medical crisis? Will we be ready for it? It is very imperative that now we have to strengthen our hospital systems, public or private. We have to work on primary care networks, responsive to their role of being the first line of defense in any health crisis. We are now faced with the reality that health and economy are bedfellows, a hard lesson to have learned through this pandemic. All these are provisions in the RA 11223 or the Universal Healthcare Act. It's there in this act, the blueprint for our health system. It might need revisions because of learnings in this pandemic, but the majority of needed policies to build a strong, responsive health system is there to guide us. So let me talk for a short period on universal health care. So what is universal health care? Because this is the parameters by which we'll be planning our strategies. This big thing happened right before the pandemic hit us. It was the passage of this landmark legislation we called Universal Health Care Act. This was very timely because it was the blueprint by which we had to reform the health system and achieve the main goal of any health system, that of providing access to all its citizens to quality, appropriate, and affordable health care. Healthcare that will not cause impoverishment as soon as you avail of it. This was the backdrop by which PhilHealth strategies and action plans were based on. Please allow me then to briefly discuss salient points of the Universal Healthcare Act related to PhilHealth's operations. This was the challenge of PhilHealth being the major financial arm of government in the health system. Universal healthcare. So what does universal healthcare means? Under the WHO definition, universal healthcare means all people have access to needed health services, including prevention, promotion, treatment, rehabilitation, and palliative services. Sufficient quality of health services to be effective, and that the use of these services does not expose the user to financial hardship. So the key points here is access, quality, and no financial hardship. So under the Republic Act number 11223, what are the objectives of this Universal Healthcare Act? One is to progressively realize universal health care in the country through a systemic approach, meaning the whole of system, whole of government, and the whole of society approach, an integrated approach. And not only that, there should be clear delineation of each role of each key agencies and stakeholders. So the keynote there is progressively realized because we know that we cannot implement universal healthcare in just one click. It has to develop systems, put systems in place, and to progressively come finally to a goal of universal healthcare in the country. Another objective is to ensure that all Filipinos are guaranteed equitable access to quality and affordable healthcare goods and services and protected against financial risk. And I think the most important word here is equitable access. Access either geographically or financially, meaning that if you don't have the means to pay, you should still have access to quality and affordable health care. So what are the major strategies of universal health care? One is to provide all Filipinos quality, preventive, curative, and palliative services, but with a focus on primary care. Second is to promote an integrated approach to healthcare delivery through healthcare provider networks and primary care provider networks. What is new here is the healthcare provider networks. Uh, I will be discussing this later on, but it's really for all the components of the health system, from primary care to tertiary care, to work together and put in referral systems so that they work as an integrated system. So the third is institutionalizing mechanisms to ensure financial risk protection by promoting predictability of payments. So this is a very important part of universal healthcare, and it is the predictability of payments. Because I'm sure everyone knows that if they have to access healthcare, then mahirap yung hindi mo alam how much you will pay. No, it's nice if you're prepared to pay because you know how much you will need to pay those services. And therefore, that's the goal of universal healthcare, predictability of payments. So this is just one slide to show most of the major components of universal healthcare. I say Filipino style because all of this is embedded in the provisions of the Universal Healthcare Act. There are three values by which the provisions or the systems are planned for, and that is equity, quality, and affordability. The components of universal healthcare Filipino style is equity. And equity, there are provisions for allocations of bed capacities for a no-co-payment scheme. That's reflected in the provisions that says 10% of the beds in private hospitals has to be a no-co-payment beds, 90% in government hospitals, and 70% in specialty hospitals. As to geographically isolated and disadvantaged areas or the GIDA areas, there were provisions for grants for networks, especially in these areas. PhilHealth to grant incentives to bring services to these areas, and preferential licensing for underserved areas. As to quality of services, goods, and devices, there is the third-party accreditation for health services, the health technology assessment, contracting, licensing and regulatory systems, and clinical practice guidelines for clinical care. Now, as to affordability, making sure that the services are affordable. For inpatient services, we have the co-payment scheme, which we're supposed to come out with. Second is benefit rationalization and complementation between all players or major players in the health sector. This is the Department of Health, PhilHealth, private health insurance, and HMOs. To ensure affordable drugs and medicines, there are provisions on the NPRI or the National Price Reference Index, availability of generics, fixed markups, transparent pricing and price monitoring, and independent price negotiation board. So all of this is embedded in the provisions of the Universal Healthcare Act. So what is the role of PhilHealth? Where does PhilHealth come into this big picture of universal healthcare? PhilHealth, as a social health insurance, ensures that each and every Filipino is protected against financial risk in seeking healthcare through risk pooling and shared responsibility among its members. So it mobilizes and utilizes its resources based on the values of solidarity and shared responsibility for healthcare needs. Also through risk pooling, risk sharing, and financing healthcare needs to finance the healthcare needs of all of its members. So what does it mean exactly? What does the law exactly say for a PhilHealth member under a universal healthcare scenario? Well, first of all, everyone is automatically a member. So yun pa lang, that's already a big thing under this universal healthcare law because prior to this law, you have to pay and enroll in PhilHealth to be a member. Under this law, everyone is a member and everyone is automatically eligible to all its benefits even without the necessary qualification requirements. This in itself fulfills the promise of universal health care or universal health coverage of the population. But this is not without implications, of course, to the funds that PhilHealth manages. And that's why we still encourage everyone to please pay the necessary contributions because and contribute to the fund that will help all members access healthcare needs kahit they are not financially capable because nandun tayo to help them out. That's solidarity. Okay. Secondly, everyone will be assigned to a primary care provider. This primary care provider will be the first and in some cases the last point of contact of a member in the health system. So earlier I mentioned that the law also provides for healthcare provider networks. So the primary contact into these networks will be the primary care providers. And it will be the primary care provider who shall help the member navigate the whole healthcare provider network system. PhilHealth will also contract with healthcare provider networks in behalf of its members in the areas of benefit availment and cost of healthcare. So that will be our role, mostly contracting with these healthcare provider networks. Lastly, healthcare spending by the member should be predictable. Contracting with providers for our Z benefits and fixing co-payment was the first role or the first activity of PhilHealth in contracting. At the start of this pandemic, when our knowledge of clinical guidelines and costs were virtually unknown, PhilHealth implemented the full financial protection for all COVID patients, meaning we paid for the full cost of the hospital bill. Of course, this was not sustainable. Therefore, when data were available, we did costing services and implemented case rates for COVID benefits. So what is universal healthcare for a healthcare provider? As I mentioned earlier, there will be an integrated approach to healthcare provider net or the healthcare provider networks. Aside from the healthcare provider networks, there will be the primary care network with patient records available throughout the healthcare system. Secondly, there will be differential payment schemes to give due consideration to service quality, efficiency, and equity. The integration will be in the provincial and the city levels. So there will be province and city-wide healthcare provider networks, hopefully, once there is full implementation of this law. Payment to providers will be performance-driven, close-ended, prospective payment schemes. We actually have started working on this, and this is a shift to DRGs or diagnosis-related groups, by which we will use this in coming out with global budget payments for our providers. But this is through contracting. So let's go now into weathering the storm of this pandemic. With the given scenarios in the health system and the implementation of universal health care, may I go now into how PhilHealth is weathering this pandemic storm. Let me first give you a few statistics of PhilHealth in its work. In your screen now is the number of members and dependents in millions of PhilHealth through the years from 2011 to present. As you see, it is increasing. The dependents are the blue portion, while the red, the members are the blue portion. So it's increasing. There are more dependents than members. Actually, the 2019 and 2020 bars reflected only the registered members, but it was 2019 when the implementation of universal healthcare started. So meaning that is now full number of our population, because everyone is a member now and everyone has immediate eligibility to our benefits. So in 2019, we started with universal health coverage of the whole population. As to healthcare providers and institutions, we have the hospitals and our other providers. No? The hospitals, as you well know, we have the level 1 hospitals, level 2, 3, and the infirmary or dispensary providers, institutions. This is also showing you the number per government or private. So we had the highest number of hospitals were the level 1 hospitals at 830. Total hospitals as our providers is 1,915. Level 2 hospitals is 345. And level 3 is 117. Infirmaries are also big numbers, 623. We have other types of institutions. No? We have the animal bite treatment centers, ambulatory surgical clinics, community isolation units, which is now which was started during the pandemic, the drug abuse treatment rehab centers, the OTS package for our TB program, freestanding dialysis clinics, family planning providers, SARS-CoV testing labs, again, which was new only last year, maternity care package providers, outpatient HIV test treatment facilities, and of course, our outpatient malaria package facilities. 60% of accredited hospitals are from the private sector. This is the number of received claims. As you can see, from 2010 to 2020, it's really increasing. Malaki ho talaga ang increase ng ating claims, especially during the pandemic when the testing claims came in. We had to find a way to address this with our human resource. We had still the same number of human resource, but increasing numbers, no? Because we were really going into reorganization. We did that in 2007, and we're due for the next reorganization, but that's still in the works. And therefore, with the number of human resource of 2010, we still have the same number now, and the claims has been increasing tremendously, especially now during this pandemic. So PhilHealth shifted to e-claims submission, which was a challenge also to the health sector because one, not everyone had access to Wi-Fi. Two, the slow speed of our Wi-Fi. It was difficult for some healthcare providers to transmit their claims to us. So that was really also an issue. And the issue in GIDA areas, or the geographically isolated and disadvantaged areas, because as I said earlier, they had no access to Wi-Fi. COVID claims in 2020 comprised 6% of the total claims received. This increased later to 27% in 2021. So there were some issues in these COVID claims, like the several unresolved policy issues. This posed challenges in processing COVID claims. So what were the strategies or the benefits of PhilHealth during this pandemic? First of all, we had to strengthen the organization. We had to do this through good governance. This was the primary concern, so as to build trust among its members, ensure continuity of support to the program. The corporation is funded through collections from its members and subsidy from national government for premiums of the indirect members. So financial stability proved to be challenging in the light of the effects of the pandemic. That is, there were some small businesses that closed, small and medium-sized, even some big businesses closed. There was OFW repatriation, among others. So these all compromised reserves to the corporation. We still have a big fund, and we can say that we can fund benefits in the succeeding years, but all these effects of the pandemic will show itself several years from now. And therefore, we have to put in more strategies to improve financial collections of PhilHealth. Including anti-fraud measures. So we have to implement anti-fraud measures. You know, in all social health insurance schemes, there is the insurance fraud. So I just want to say that we're not pointing at our healthcare providers that all of them are committing fraud. That's not true. We know that it happens. We have found some, but these are the bad eggs. The whole health sector, I'm sure, are made up of honest facilities and honest professionals. But we had to implement these fraud measures. So in this new scenario of quarantines, isolations, and social distancing, there is no other way to go but digital transformation, especially for processes needed by our members. You know, when they register to us, when they pay their contributions, we had to go full digital transformation. Again, we have made a big strides in this area, but there's still a lot of things to do in this area. So we have developed member portals for our members to be able to transact business with the corporation. We are now expanding our storage facilities like cloud and other IT reforms. So how did we address member benefits? One, as I said, one very important thing is to improve access to primary care. The lessons of this pandemic showed that we have to strengthen our primary care networks for IEC to be done to inform people that the lifestyle, you have to improve lifestyles, improve your immune system, because by doing that, makokontrol natin yung pandemic, no? Because we will not be able to, hopefully, we won't be getting the virus, the infection, and transmitting to other people. So we have to strengthen ourselves, our own immunity, to be able to help not only us, but others. Okay. We also expanded inpatient services, which I will be mentioning earlier. We had to go into partnership and cooperation efforts in implementing benefits, like, for example, testings. And we had to provide ample financial coverage for Filipinos in essential health services through our provider payments and no balance billing policy. So on preventive care, we are implementing a program called Consulta. This is our way of strengthening primary health care to better address any other medical crisis that might come. Consulta will benefit all Filipinos. No? It's full implementation. We haven't fully implemented it. We implemented it on a pilot basis this year, and we're planning to implement it on a nationwide scale later this year or early next year. So the beneficiaries will be all Filipinos, and that we hope to register all Filipinos to a primary care provider of their choice. A benefit package will be 500 per capita for public facilities and 750 for private facilities. These are all tentative. We may change these computations depending on feedback from the pilot sites. Payment mechanism will be through capitation, and it will be performance-based. So the target for payment release will be 40% upon registration and 60% upon performance. So what is included here? It will be initial and follow-up consultations with a primary care provider, targeted health risk screening and assessment. There will be diagnostic tests, 12 all in all, and drugs and medicines, 19 molecules all in all. So we are inviting all providers nationwide to come be accredited under the Consulta package. So these are just the services and laboratories and medicines included in the Consulta. As I said, all these are tentative. We're still improving on the design of this Consulta, but hope to implement it nationwide before the end of the year or early next year. So what were the COVID benefits that the corporation implemented? PhilHealth follows the one command strategy in dealing with this pandemic. It is anchored on universal healthcare provisions and the National Action Plan against COVID. Pursuant to this nation's goal of containing and addressing the ongoing pandemic, PhilHealth is committed to contribute to this initiative by ensuring continuous provision of benefit packages for testing, community, and inpatient care that protect all Filipinos from catastrophic health spending. So, what is the national strategy of the government in fighting this pandemic? It's the PDITR strategy. P is for prevention, and this is aggressive advocacy campaign, and of course the national vaccination program. 2 is detection, aggressive contact tracing and expanded community testing. Isolation strategy, we have isolation facilities for mild symptomatic cases. We also have a new benefit wherein mild and asymptomatic cases can now be managed at home. We have community protocols for positive cases. Isolation also ensure adequate PhilHealth coverage to encourage facility-based quarantine if necessary. And as I mentioned, the home isolation for mild and asymptomatic cases. Of course, the T is for treat and to reintegrate, the strategies for treat and reintegrate. The National Vaccination Program. The contribution of PhilHealth here is the COVID-19 Vaccine Injury Compensation Package. It is a lump sum payment of up to 100,000 for adverse events leading to permanent disability or death. Now, as to adverse events needing hospitalization, it is an additional amount of 100,000 for hospitalization. The hospitalization package will be on top of the regular PhilHealth benefits, and it will be paid directly to the beneficiary based on the remaining hospital charges after PhilHealth benefits and discounts. On the detection strategy, PhilHealth initially released the package for the RT-PCR test in April of 2020, and we came out with a package costing that we costed. But a couple of weeks or months after the declaration of the state of calamity, testing kits became more widely available, and therefore we had to adjust the cost of testing that we paid for. Still on the detection strategy and partnership and cooperation efforts, PhilHealth partnered with the Philippine Red Cross because they had the capability of more expanded testing. Therefore, we signed a memorandum of agreement for payment of COVID-19 tests done by the Philippine Red Cross. So these are the numbers of claims that we received and the amount that we paid. We received a total of 4.4 million claims of testing, 1.7 million of which is from the National Red Cross. Of course, the RT-PCR test over the cartridge base was a bigger in number. This was 2.7 million, while cartridge-based PCR test so far is 1,518, which we're still processing. So a total amount of 8.5 billion has been paid for testing. On the isolation strategy, PhilHealth paid for community isolation benefit packages admitted in community isolation units. Usually these units are run or managed by the local government units. So CIUs are DOH certified, public or privately owned, non-hospital facilities set up in coordination with the national government or the local government units to serve as quarantine facilities for COVID-19 cases. So PhilHealth came out with a community isolation package or the CCIBP. So how much did we pay and how many? Community isolation package was a total of 59,177 with a total amount of 264 million pesos. Next is our inpatient benefits. So there were a lot of drivers that increased the cost of inpatient hospitalization. One, the extended length of stay. Medicines were expensive, uh, especially the antiviral medications because they were new and not very readily available. So they are and still is very expensive. Of course, the PPEs contributed to higher cost of inpatient care. Uh, Health workers, of course, had to protect themselves. And aside from the PPEs, if they were admitted for critical care, ECMOs or renal replacement therapies were also contributing to the high cost. As I mentioned earlier, all Filipinos are deemed eligible for any benefits, inpatient or outpatient. And therefore, we had this treatment strategy of benefit packages for inpatient care for at the start of the pandemic, probable and confirmed, because at the time we were not yet very sure about our testing results, and therefore probable cases had to be managed as COVID cases. So we embodied this in a circular and came out with different costing for mild, moderate, severe, and critical pneumonia cases of COVID. But before we could come out with that, having no data on costings for a benefit, we implemented a full financial risk protection for all Filipinos before April 7, from the start of the pandemic until before April 7. We paid for the whole hospital bill of those confined because of COVID. We also have a full financial risk protection for all Filipino health workers who needs to be confined because of COVID. And we also have we now implemented an intermediate benefit package because um, we have an expanded capability now for testing. Results are more accurate, and therefore we know whether uh, through the test if they are positive or negative. Of course, we recognize also some false positives and false negatives. But because of this, we came out with the intermediate package to cover cases that were initially thought to be COVID, but later turned out to be negative in RT-PCR test. So this shows the number of inpatient claims received and the amount. To date, as of August 9, we have a total number of claims is 35,000 plus, 35,358, totaling 945 plus million pesos. So as you see in the graph, most of the cases of inpatient were in the moderate pneumonia, followed by the critical pneumonia, then severe pneumonia, and a few hospitalized for mild pneumonia, because our policy says that um, hospitalizations for mild pneumonia should be with the elderly or those with comorbidities. That is in line with the DOH guidelines. We also expanded our existing benefits because of effects of pandemic. We know that a lot of people lost their jobs or had decreased earnings, and therefore it was incumbent upon us to help out, especially those having hemodialysis sessions. Therefore, we extended hemodialysis coverage from 90 to 144 last year, and this year we again expanded the number of sessions. We also implemented the PhilHealth portal for members to be able to contract services, their businesses with us. And we also canceled temporarily, at least during this national emergency, the policies of single period of confinement and the 45-day limit, which was part of the requirements, which was a policy of PhilHealth prior to the pandemic. To respond to the issue of payments that took some time or long turnaround time of payments, well, this happened because of a lot of factors. One, as I mentioned earlier, the number of claims that came in increased tremendously, especially the testing claims that came in. Aside from this, prior to the pandemic, PhilHealth already received claims through e-claims, and we in the initial stages were processed digitally, or it was automated. But during the pandemic, realizing that there was a clamor to allow providers to submit claims manually, we allowed this. And this therefore also contributed to some increase in turnaround time because we had to encode um, the claims that came into us manually. This also was true for, especially for the testing claims, because most of the testing laboratories were not capable of submitting electronically to PhilHealth. They still had to improve their capabilities on this. Aside from the fact that some documentary requirements like the CIF form that the Department of Health required for contact tracing, the CIF, had to be attached for every testing claim because this was a requirement of the DOH. And therefore, that contributed to some delays in our claims processing. Therefore, we implemented a new payment scheme called the debit credit payment method, wherein we paid 60% outright of the total applicable claims. In other words, the claims that were being processed in our offices for those healthcare institutions that were qualified to come in under the DCPM. And these are the healthcare institutions that handles COVID claims in areas identified by the IATF as surge areas. So these are the areas under ECQ, MECQ. So the hospitals under these are qualified as long as they manage also COVID cases. So 60% of the total amount can be given to them upon signing of an undertaking, and the remaining 40%, of course, minus the withholding tax, will be released once we liquidate, once we process the claims and liquidate and see whether there are some deductions. In other words, we reconcile, full reconciliation of the 60% before we release the 40%. So far, we have paid a total of 6.5 billion for this DCPM to 232 healthcare institutions. So we are already expanding the DCPM to other, well, we're expanding first the coverage from before it was only until April 7. We expanded it to coverage for claims to August 9. So there will be more funds released to the hospitals that are availing of this. And we are planning to expand it more to other areas, even if they're not identified IATF yet. But that again is tentative. We're still studying this and hope to come out with expanded provisions for the DCPM. Okay, so there are still additional COVID-19 related benefit packages such as the tent accommodation. There's been a clamor for this. We know that the hospitals that are catering to COVIDs are full and that some patients cannot be accommodated anymore in rooms. And therefore, the hospitals address this through tent accommodation. We have come out with a policy wherein as long as they are admitted, then they can charge us for accommodations in areas such as the tent or even emergency room. If there are no other rooms, as long as they are part of the inpatient period for confinement. We also have the COVID home isolation benefit package. I mentioned this earlier. This is for the mild COVID cases or asymptomatic COVID cases, but are RT-PCR positive. Therefore they are confirmed cases. So they can be managed at home. Of course, it should be through a accredited healthcare provider. And we're encouraging healthcare providers to get accredited for this package. The payment for this will go to the providers and not to the patient. And there will be some mandatory services under this, there will be face-to-face initial consultation and succeeding virtual consultations and MOA with a referral facility just in case a patient while on home isolation will deteriorate. There's also a kit included. It includes a pulse oximeter, a thermometer, and some supportive drugs and medicines. So that's for the home isolation benefit package. This is in response to the observation that in surge areas, our hospitals are already full. And therefore, we want to decongest this of the mild and asymptomatic cases so hospitals can focus on moderate, severe, or critical cases. We are looking at additional tests. We're looking at funding additional tests for COVID-19, such as the saliva-based PCR and the rapid antigen test. We've heard this too often. These are very challenging times. Never did we anticipate a complete change in lifestyle to happen within our lifetime. But the greatest danger in times of turbulence is not the turbulence. It is to act with yesterday's logic. This was by Peter Drucker. So my friends, I hope each and every one of us finds that new balance we need in this ever-changing, unfamiliar world. So thank you very much and keep safe, everyone. Good day.
Our speaker is a doctor of medicine obtained at the Davao Medical School Foundation. He is a former commercial and airline transport pilot, a PADI scuba instructor, and a president and owner of number 1, Davao Airworks Corporation, 2, Hydromax Commercial Diving and Salvage Corporation, and 3rd, Global Merit Finance Center Corporation, to talk about money matters, the financial stability and literacy as health workers. Everybody, let us all welcome Dr. Albert Pingoy.
Good morning, everyone. Thank you for inviting me to share a little bit of personal financial management. No? So what is personal financial management? Simply means gaining an understanding of your financial situation in order to make the most out of your asset in day-to-day life, personal life, and planning for your future. This is different from business management and other things. So it's more of a personal, So I took up my pre-med BS Biology in Ateneo de Davao in 1986. And right after that, I proceeded to medicine proper in Davao Medical School. I could not remember that we were taught even one unit of accounting or personal finance management. In high school, we were taught algebra, trigonometry, and other complicated mathematical equation, pero it seems like it's not relevant no, for unless you become a physics or engineer. But I remember in elementary, primary school, we were taught four mathematical equations, which is, I think, the only thing that we need, and plus some others. So it's addition, subtraction, multiplication, division, and some percentage and ratios. That's all we need to be able to manage our personal finances. So it's not really that complicated. However, it's just not introduced to us. I hope when I got my medical course more than 30 years ago, it was not included in the syllabus or the curriculum. Hopefully, currently, I hope that it's already included because it's very important. Because personal financial does not take care of its own. You have to do it. You have to manage it yourself. It does not mean that even if you have a good practice, if you have a good career, your finances will just follow, will just take care of its own. Actually, it's most of the time it's not. No. So let's go into steps and how to manage it. The first step is to determine your current financial situation. We have to know, it's like if you have a map to navigate, you have to know first where you are in the map. So you have to know, segregate your assets and your liabilities. You have to take inventory of what you have and what you owe, such as loans, lease, expenses, income in a household if married, no, because it's conjugal, and including cars and houses. And we have to do this to be able to know and be able to strategize. In fact, houses can be both an asset and a liability. So every situation needs different approaches. So the reason that you have to determine your own financial situation is because there's no such thing as a one-shot deal for everyone. After knowing your current financial situation, maybe maybe determining if we are ahead or even if we are on the red, meaning kulang, we have more liabilities than assets, or we are doing well, we are ahead of the game. Next is we have to develop a financial goal. And these goals have to be smart goals. So it has to be specific, measurable, attainable, relevant, and time-based. So we just could not say, it's okay. It's just, I just want to earn just more than enough of what I need. What is more than enough? So it has to be specific, such as you have to say 30 millions in 20 years, time-based, and it has to be measurable. Let's say you have to break it down. Let's say 30% real estate, 30% comes into portfolio investments, or another 30% from your practice, investments, or business. It has to be specific and it has to be time bound. 30 millions 1 year from now is different from 30 millions 30 years from now, or 30 millions you have it already in the bank. So the difference is what we call the net present value. So let's just skip on that first, and let's move on to the next. No? Once you have the financial goal, next is financial goal is your target destination. So first, we know where we are, and next, we know where we are going. This time, we need to create a budget and pay yourself first. And this is your vehicle to be able to reach your financial goals, targets, or your destination. With this, you need to create a budget and have a discipline to stay with it. And a good rule of thumb is to start with 10% set aside from your gross income monthly. And then you may be able to spend the rest. So income minus savings of at least 10% and gradually increase it. And the rest is for expenses. It should not be the other way around. Na income minus expenses, and you try to save whatever is left. More often than not, there will be nothing left to save. So, discipline is very important. And then discipline and just stacking up on good habits. So once you create a good habit, and it usually takes only about 21 days to create one. Habits are just recurring activity. Let's say if you save, you budget. After that, come up with another good habits on top of a good habit. So life, you get ahead in life if you have more good habits than bad habits. You get behind in life if you have more bad habits than good habits. Easier said than done, but very important to stack up on good habits. So right now, it's just a general form. We can go to it in the question and answer portion later on. But it's more of accumulating good habits. Next is insurance protection. You should be covered right away and properly. Since we are a medical health worker, we have to custom fit. You have to talk to your insurance guy, because there are certain products that may be offered to you that might not be appropriate for you. Why? For example, we work for SPMC. Well, we have some benefits and privileges by working in a health institution such as SPMC. So if we work there, we get a zero billing plus our, including our immediate family, right? And this is not true with others. That does not work for SPMC or other medical institution. And we know our colleagues there, they take good care of us. Zero billing. So do we really get a premium insurance? Do we really need it on top of our basic HMO and PhilHealth? Probably not. Not the same as the others. But you have to talk to your insurance guy about that. Another thing is try to avoid combining insurance with investments. I'm not. Maybe there are some insurance broker that is listening to me right now and might not like what I'm saying, but this is true. If you combine insurance with investment, usually with VUL, a lot of commission is taken away from you right off the bat. And for me, it's better off if you have a term insurance, and then you can automatically, what is left, invest in an automatic investment products that are very much conveniently, you can do it online very easily. After insurance protection, you have to build an emergency fund. It used to be that the rule of thumb is between 3 to 6 months, but the new rule of thumb is about 1 to 1.5 years of monthly expenses. This, you might think that this is a big amount of money. Yes, it is. Especially if you think you will start with 10% of your monthly income. So it would take you about a year to come up with 1 month of to cover your 1 month of monthly expense. However, you don't have to have this right away, but you build it as you go. And later on, this will take care, and instead of having your own insurance, paying for your insurance, once you build up your emergency funds big enough that you can self-insure yourself. So meaning you save more money if you don't, if you have these emergency funds set aside, and instead of paying insurance, you keep it, and then you add it to your emergency funds. And there are many ways how to do that also to increase your emergency funds, like you increase the credit limit of your credit card, but you don't use it. But that credit limit will always be available in terms, in times of emergency. So, but you just have to have the discipline not to dip into it and use your emergency funds for consumerism, because that would be you going backwards instead of forward. Next, I might have jumped earlier, but the next slide is you need to manage debt. So we need to manage that it should start very early, because debt usually snowball. And not all debts are created equal. There are good debts and bad debts. No, so good debts are the loans that we take to make more money or to add another income source. Bad debts are those debts that take away money from us monthly, consistently, regularly. So it puts us back instead of moving us forward. Try to avoid as much as you can consumer debts. No, because especially credit cards, because it can be very exorbitant, and they charge usurious interest if you do not pay 100% monthly. However, if you can pay whatever you have used every month, 100%, then credit cards are very convenient. And at the end of the month, they will even give you printouts of where you spend your money. And this can another way of helping you to manage your finances. But avoid not paying the whole amount, or for your personal consumption. You can use credit card for business. Later on, maybe we can discuss some more how we can use credit cards for business. I remember that I opened a convenience store, 6 branches of convenience stores, and for credit cards, you're allowed to use their money for 51 days without interest if you know the timing. So I would buy large amounts of inventory from SNR, sell it. It's a convenience store, and before 50 days, because in convenience store it's all cash basis, we can pay it back, all that we need to pay. So we don't incur any interest rates, but it is very convenient, and at the same time it gives me some allow me some capitalization that I do not have. Next is planning for retirement. Planning for retirement also includes all that is necessary, and especially sending your kids to school. You do not plan for just your own retirement, but also for whatever the kids are needing. And kids are not part of the retirement plan. So meaning you don't plan to have many kids and then hopefully that they will take care of you once you get old, and you jump from one kid to the other, from one child to the other, and you let them, you have to have your own thing for that. And have an exit strategy as early as you can. Exit strategy, it's not too early to have one, and it can always be too late, but it's never too early to have an exit strategy. Next Once you have a complete plan from savings, budgeting, management debt, and also planning for your retirement, this is now the time to increase your cash flow or income. So try to strive for at least 3 income streams. Usually, I would not recommend that you increase your cash flow or income if you haven't had any budget plans at all or emergency plans, because usually if you don't have that in place, once you increase your income, your lifestyle creeps up to your income. We call it an lifestyle inflation. So it goes up also. Your lifestyle goes up with your income. And then there's not much left for you to be able to stock up and accumulate. So the best thing to do is increase your income, but make sure that your lifestyle is steady. So with this, increase your income, steady lifestyle, this will be your wedge of wealth. It's not that as you increase your income, your lifestyle goes with it. So at the end, you don't really get ahead. You're just pushing, coasting along, and you're pushing everything forward. Now, next is once you have increased, find a way to increase your cash flow or income. Sorry. So think about investments, business, or side hustle. So I would strongly suggest that you invest, you go into business or side hustle that you understand. There's a lot of business opportunities right now. There's a lot of investment opportunities, but you have to increase your financial literacy first before even diving into it. You can easily lose your money, hard-earned money. No? So to avoid that, you have to understand what you're doing. Sometimes it's fashionable to discuss about Bitcoin, even if you don't understand it. 95% of people who invest in Bitcoin lose their money, but they will only mention the small money that they have earned, but they will not tell you the big amounts of money that they have lost. So sometimes it is even more, it's better if you have your small side hustle online. Some, they make money selling plants, selling pets, fish, dogs, birds online, more than people who have invested money in other fashionable instruments. It's a very good piece of conversation if you're in Starbucks, but make sure that you only do things that you understand. I know some doctors that make money side hustle, like anesthesiologists who make photography of the cesarean section or whatever. And there's so many businesses that you can go into, like even a home care. So there's so many things. If you go into that, another rule of thumb or the rule of 72 is always a good uh, thing that can guide you along your way. No? So the rule of 72 is a simple way to determine how long an investment will take to double given the fixed annual rate of interest. So there's an example there that if you do a 10% annual fixed interest on your money, on your investment, principal interest, so it will take 7.2 years to double your money. So this is how you compare one investment from the other, or how one business from the other. So it's a good measurement. Lastly, once you have your plan, try to stick and follow your plan. A lot of people would jump from, it's like going into an elementary school. You don't go to grade 6 if you haven't had finished your grade 5 and grade 4. A lot of people would like to jump because it's fashionable. It sounds impressive, maybe. They would go into investments without having emergency plan in place, no budget and no savings to set aside. That's very difficult to do because investment without the basic fundamentals, you might be going backwards and then losing a lot of money. So the money that you even could not afford to lose. So that's why follow your plan. Or you have to change your plan and follow it. So you have to change every time, let's say 5 years, 3 years, you have to revisit your plans, and but you have to follow your plans. Having no plans at all is also one of the major reason why people do not get ahead in their financial goals. I believe this is all I have to say. There are a lot more information online on these things, and I would be also happy to be able to help you. If you have anything, please let me know. And daghang salamat.
Let's hear from our friends from J&J. Our guest sponsor speaker is a graduate of UER MMC and of Corazon Lacson Montelibano Memorial Regional Hospital, specializing in orthopedics and traumatology. Finished subspecialty trainings in Seoul, South Korea, and in Nara, Japan, to speak on pain control in office orthopedics, Dr. Juan Agustin Coruña.
Hi, good morning. My name is Jinkin. Thank you for having me. I'd like to congratulate SPMC's Emed department for successfully holding this postgraduate course. The title of my topic is as follows. I am from Bacolod. We have a lot of sugarcane. We deal with a lot of broken bones despite the typhoons. And I'm a junior partner in my dad's practice. In Western Visayas, I direct the Foot Institute. We produce a lot of research for the region and the country. And these are Toto Tudlo and Dr. Tiil, your partners in healthcare. These are the disclaimers for Johnson & Johnson. These are mine. I declare no conflicts of interest for this presentation. And I'd like to reach three things before I end. I'd like to talk to you about the pathophysiology of pain. I'd like to show you my cases, and I'd like to show you the scientific evidence why I use tramadol paracetamol in my clinic or even in the operating room. So this is the anterolateral pathway for pain. And you can see from bottom going up, transduction, transmission, modulation, and perception. When you have a noxious stimulus activating the nociceptor on your skin, it gets transduced and then transmitted to the dorsal root ganglion, where it will decussate and go up to your cerebrum. From there can be feedback mechanisms in order to modulate where the pain is or to affect the pain control. Perception would tell us where the pain would be and if we can numb these. So basically, you have a lot of molecules in mind, a lot of molecules to choose from. And I'll be showing to you why tramadol paracetamol is a good option later on in the next few slides. But the more pathways that you use, the more pain pathways are blocked, the more comfortable the patient will be. So in 1986, the World WHO already presented the pain ladder. And as you go up, mild, moderate, severe, you can modify your weak opioid to become a strong opioid, and then you can include other molecules such as NSAIDs or even adjuvant therapy to help the patient with pain control. If you're going to be comparing NSAIDs and tramadol paracetamol, you can clearly see that the check mark in severe pain is pertaining to the rightmost column, and you can use it for your elderly patients, geriatric patients. You can also use them for your patients at risk of cardiovascular disease as well as renal failure patients. And the mechanism of action is that paracetamol, though it still eludes science, there is inhibition of prostaglandin synthesis for COX-1 and COX-2. For tramadol, it's mainly a mu opioid receptor agonist, but it's also a serotonin releaser and a reuptake inhibitor for norepinephrine. So it just shows that there is a central and a peripheral effect for tramadol paracetamol. So this is an orthopedic surgeon. I take pride and I am very happy that colleagues of mine in the allied medical health go to me for assistance with their extremity problems. So this is an orthopedic surgeon. This is an emergency for him simply because he cannot do rounds. So you can see an obvious distal medial subungual onychocryptosis on the right hallux. And it's quite surprising to see your colleagues having these. But a lot of my inguintonal patients, up to 30% of them, are actually nurses, residents, orderlies in the hospital. So in my facility, we do a simple digital block. We apply a ring tourniquet. We do the excision of the nail fold. We can choose to do a chemical matrixectomy. And then in as little as 10 minutes, it's already finished the procedure. So you can see that the lateral nail fold or the medial nail fold for this patient has a very long proximal horn. And there's a very sharp edge that grows in through the skin. And for every 3 days, there's a millimeter of growth on that toenail. There's also a millimeter of soft tissue impingement that causes the erythema and subsequent tearing of that integument, leading to sometimes infection and other inflammatory processes. So this is 2 weeks post-op, 1, 3, 6 months post-op. The orthopedic surgeon has been doing rounds since day one of the procedure. very happy. You also have to control the pain. Tramadol paracetamol is very effective for these conditions. This is another patient with distal lateral and distal medial subungual onychocryptosis. The lateral nail fold is infected. There is some drops of pus. I'm applying the ring tourniquet. That's the English anvil. We've snapped the nail folds off. We're completing it with a knife incision. We're using a curved hemostat. We're pulling off the very long horn of the medial nail fold. We're now proceeding to the lateral nail fold. This is the chemical matrixectomy using a silver nitrate stick. It's chemical cautery. We're disengaging the cautery with H2O2. We're applying an iodine ointment. We're putting the hallux band, and the patient should be able to do his or her usual activities. These patients are in pain. You should control that pain for them to prevent reflex sympathetic dystrophy. So a lot of my patients can also come in with bilateral ingrown toenails and both medial and lateral nail folds affected. So you really have to address all four. And 1 year later, they come out very happy and they come to you visiting simply because they're happy and grateful of the services you've done simply by treating their pain and treating the ingrown. So you really have to do a careful history in PE. You have to talk to the patient, you have to touch the patient. Some of my patients have chipped nails with resin. You can reconstruct it and then you can add already nail polish, and they're so happy wearing their beach shoes. But again, you really have to look at the patient or touch the patient, because sometimes these patients may have an onychomycosis. Some of them may have a tuft osteomyelitis that will make it extremely challenging to treat the entity. If you're unaware of the entity, it is so difficult to treat the problem. You really have to know what the problem is. So the misconception is when you operate, they say that the acute post-op pain will vanish after a few days. They also say that if the surgery was very good, it was successful, the pain will soon be forgotten. So in the emergency department, you do a lot of procedures, and these are procedures that may be mundane to you, but it may affect the mobility of the patient, it may increase their mobility, it may delay their recovery time. So patient education is very important when you're talking to them, when you're building that consent for them to give you the go signal to proceed with the surgical procedure that you want. Pain is also underrated. If you look at the red and gray columns when it's any pain or even extreme pain, comparing a decade in 1993 to a decade in 2003, the pain seems to have increased, especially for extreme pain. And we should really control this because it increases the morbidity of the patient, it affects the activities of daily living of the patient, and it may be very predictive of the patient developing chronic pain from a very simple or a very complex procedure. So this is just a prospective cohort comparing 179 different surgical procedures by Gerben Schagen. And you would note that there is no emergency room procedure that you see here. So nothing that will condone Emed's practices. But the green arrow points to orthopedics. So if you look at all the green columns in the middle figure, you can see calcaneus, you can see spinal fusion, you can see foot arthrodesis, joint fusion. It's mainly orthopedics simply because we do a lot of bony work. And there is also an associated cutaneous nerve manifestation that needs to be addressed. But when you review all these surgical procedures in orthopedics, there is severe pain after surgery, and it can be in 20 to 40% of the population. And you don't want that to happen simply because that patient can be your mother, that patient can be your sister, could be your household helper, that patient can be you. So you really want to take care of that. Post-op pain, 80% who undergo surgery report post-op pain, whether it's mild, moderate, or severe. But most of these patients will continue to be moderate, and less than half of those post-op patients will receive adequate pain relief. So do not trivialize when a patient says that he or she is in pain. Give the pain medication, let them be at peace, and they will have better outcomes. And it's really seen as a sound practice in many institutions. This is my setup for wide awake local anesthesia, no tourniquet, Wallan. So you have epinephrine, you have lidocaine, you have plain NSS. This is a patient, look at the long finger, it will catch, tok, right there. So that's a trigger finger. The A1 pulley is impinging on the flexor digitorum of the long finger. And then we're just applying the hand positioner. If you look at the yellow arrows, there's an area of tumescence. It looks pale. That's the effect of epinephrine with anesthesia with lidocaine. And when I operate, I get to see the skin, subcutaneous. I see the A1 pulley. I get to release the A1 pulley, and that's the wound closure. We get to see the hand. You look at the long finger. There's no catching anymore. The triggering has been resolved. Very quick procedure, 5-minute procedure. This is a patient. The previous patient was psychiatrist. This patient is a pathologist. And again, when you use your hands, when you write, when you type, when you use your feet to walk around for rounds, all these patients are doctors. And any doctor in need will always be an emergent procedure. And doesn't have to be a doctor, can be a nurse, can be an allied health professional, medtech, radtech. You have to treat them all. It doesn't demarcate as an elective procedure anymore. So that's the area of tumescence. You can see the area of pallor where I've injected the epinephrine. That's the surgical exposure. You can see the APL. You can also see the EPB, Apple EPOB, the contents of your first dorsal compartment. There was an associate ganglion cyst, which was also excised for this patient. And this patient had carpal tunnel syndrome. Again, you can see the area of tumescence pointed by the yellow arrows. There's pallor from the epinephrine. From left to right, you can see the transverse carpal ligament. You can see the freer elevator under the transverse carpal ligament. Now you can see the median nerve in its full glory. And this is the wound closure. Eventually, these patients, they get to do rounds, they get to see patients, they get to be beneficial members of society to help those who are infirmed, whether mentally or physically. Now, when we do expected outcomes, we really have a complete pain-free post-op period. That's tantamount. You don't want the patient to feel pain. Or if they do feel pain, they feel it as a 2/10 pain in the vascular. It is aided when they move their hands, they move their feet. Mobilization is life, mobilization is key. It enhances recovery, it prevents muscle atrophy, it prevents reflex sympathetic dystrophy. Now, when you look at pain and recovery, you can see it from your perspective, from the patient's perspective, as well as the hospital's perspective. From the hospital's perspective, it's an increased length of stay, and that would be uh, counterproductive for them to fill in the beds, to probably earn from health insurances or HMOs. From the patient, it doesn't make them productive. It affects how they sleep. It affects their relationship with their home members. For the doctor, it can be a source of litigation. It can be a source of sleepless nights also. So what's the ideal pain drug? It's a combination of analgesic products that activate multiple pain pathways. Again, from transmission, transduction, modulation, and perception. If you combine drugs, there's a potential for reducing adverse events, and you are really looking for a synergistic effect. Now, this is a patient who sustained an ankle injury by falling off the motorcycle. I cannot stress enough that you should wear shoes when you're driving a motorcycle, simply because patients wearing slippers or no footwear at all have soft tissue skin injuries that are very, very challenging to treat, especially with high energy trauma. So we have a lateral ankle malleolar fracture. Again, this is a Walland procedure, no spinal anesthesia, no general anesthesia, all in the operating room. All can be done in the emergency room, as I've shifted my practice to regional blockade and local anesthesia. Again, Walland. You can see the barbotage. The syringe is on the fractured line. You are aspirating the hematoma and re-infiltrating the anesthetic back. The tumescence, again, in yellow marks. This is what the primary reduction looks like, provisional. And then this is the gross wound. This is what the patient looks like when we're stressing it in range of motion, plantar and dorsiflexion, varus valgus tests. This is the post-op x-ray of the patient, taken within the same day. Patient was sent home the same day. Patient follows up at 3 months, already able to heel walk and use the ankle with full weight bearing. This is a patient who sat on the bed and didn't know that there was a needle inside the bed. And on x-rays, on lateral, oblique, and AP, you can see that fine pin, that's fine needle inside the soft tissue. So the best thing for you to do is use your ultrasound at bedside. You can see it in the transverse and in the long axis plane. You again put Walland the area of tumescence in yellow, and then you open it, you get to see the needle immediately. You don't have to look for the needle in the haystack, and the patient can go home. After suture removal in 2 weeks' time, patient can also be followed up for possible cutaneous manifestations of neuralgia. So this is by Shug, combination analgesia, rational approach. Basically, you should have complementary pharmacokinetics and MOAs for your drugs, multiple pain pathways, genuine synergy. Tramadol can work in as early as 20 minutes. Tramadol will then have a prolonged effect of 7 to 9 hours when paracetamol wears off. So you have rapid from paracetamol, you have a sustained pain relief from tramadol, and it is greater together as compared to giving it paracetamol alone, tramadol alone. So this graph, this nice figure just reiterates the pathways of pain that we mentioned earlier. And then this table just shows that if you combine paracetamol and tramadol, the combined half-life becomes 79 hours instead of 5 to 6 hours if it were tramadol only. This is from Sawadiruk, outpatient hand surgery. They found out that tramadol alone in blue and Dolcet group in red. In red, you can see decreased VAS scores as the time progresses. This is by Mochizuki et al. They had knee replacement patients, and column A, tramadol paracetamol, column B, NSAID group. The NSAID group almost had ambulation after knee replacement 1 day later as compared to those with tramadol acetaminophen who were able to walk without cane assistance anymore 1 week after knee replacement. So again, it's very important to educate your patients on pain control. You also have to educate them if they don't feel pain, especially for patients with diabetic polyneuropathy. A lot of them will complain of tingling, a lot of them will complain of numbness, no sensation, but some of them will even complain of somewhat radicular pain, which may be referred pain from the spine or even from the lower extremity. It's also important for us to prevent ingrown toenails simply by cutting our nails properly and not wearing tight-fitting shoes. But again, if it's a healthcare worker, it's always an emergency. I'm very happy to be talking to you once again. Congratulations again to the Emed department of SPMC. So for the final take-home points, tramadol, paracetamol, both have different mechanisms of action. They affect more pain pathways, so the patient is more comfortable. It leads to less opioid use, faster recovery time for the patient. My name is Chinkin. I'm from Bacolod. Thank you for having me. Good morning.
Mula sa isang hangarin, umusbong ang isang pangarap. Isang pangarap na makatulong sa bayan sa pamamagitan ng pag-aalaga sa kalusugan ng mamamayang Pilipino. Isang pangarap na itinaguyod ng pagmamahal. Pagmamahal na nagbibigay lakas upang mapagtagumpayan ang mga hamon ng panahon. Kami sa Natra Farm ay taus-pusong nagpapasalamat sapagkat patuloy kaming binibiyayaan ng mga kasama, kaibigan at kapamilya na may katulad na hangarin. Mga kaibigang walang kapagurang nagsusumikap at nagpupunyagi upang mapangalagaan ang kalusugan ng ating bayan. Isang natatanging karangalan ang makasama ninyo sa inyong adhikain. Dahil sa inyong paniniwala, patuloy kaming nagsusumikap na magtakda ng mga pamantayan upang maitaguyod ang mataas na antas ng kalidad sa paggawa ng epektibo, ligtas at abot-kayang gamot. At dahil sa inyong pagtitiwala, Lalo pang umigting ang aming paninindigan na maglingkod sa ating bayan at patunayan sa buong mundo na kaya ng Pilipino. Sa paglipas ng panahon, tayo ay patuloy na pinagbubuklod ng pangarap, pagmamahal at pasasalamat. At anumang hirap ang ating daranasin, sama-sama tayo sa paghabi ang isang pamanang hindi madaling makalimutan. At sa paghahanda namin sa hinaharap, lalo pa naming pagtitibayin ang nagbubuklod sa atin, ang mga pangarap na bumubuhay sa ating isip at diwa, ang pagmamahal na nagbibigay kulay sa lahat ng ating gawain, at ang walang sawang pasasalamat para sa lahat ng ating narating at sama-sama pa nating mararating. Mula sa aming pamilya, maraming salamat po. Patuloy ang nagmamahal Natra Farm.
Our last speaker for this morning's session, she is an anatomic and clinical pathologist. She works with the Subnational Blood Center, DOH7, works with different molecular laboratories in the various regions of the country, DOH7, CTRL, ARC Hospitals, PNP Region 7, Biopath Diagnostics. She also works with General Clinical and Surgical Laboratories, BPMC, Adventist Medical Center Valencia, Polymedic General Hospital in Malaybalay, Bukidnon, and in Bethel Baptist Hospital. Currently, she's also the spokesperson of the VBOC, or the Visayas Vaccination Operation Center. To talk about where are we now, COVID-19 variants and vaccination, Dr. Mary Jean P. Loreche.
So magandang araw sa ating lahat. I am very much honored and privileged to be invited to speak before this, one of the specialties that I really look up to would be our emergency medicine doctors. I have a very good understanding of how they are and where they are, especially in this pandemic. And so my topic today would be, where are we now? Considering that we have our various variants of concern already and the ongoing vaccination. So we'll start with this. I know that most of you, because I believe that the attendees are mostly doctors, ER specialists, of course, our emergency medicine tech, and everybody else in the paramedical medical field. So we have to understand basically why we do have these variants of concern. So we always start with the basic, and that would be your mutation. The mutation is actually a change in the sequence of a viral replication. In most of my talks where I discuss variants of concern, especially Delta, I would liken it to a very simplified version of when you copy something. Sometimes what you copy is different from the original one. So in a classroom, if you are going to copy from your seatmate, and another seatmate will copy from that seatmate onwards until the last person in the classroom, there will be changes already in the way that you copied the answer. Maybe not much on when it is an ABCD type of examination, but when, for example, in the bar exams, or maybe when we took up our ethics and legal medicine classes, wherein, you have to give very long answers. So when your seatmate would copy from you, definitely there will be changes. And that is what is happening in a mutation in a virus. And RNA viruses are notorious for this, particularly coronavirus belonging to the RNA viruses. So when there is already a difference in the genome or in its copies, then you call that as a variant. And when there is already a demonstrable change in the way in terms of virulence or antigenicity, then you call that as a strain. So We have to discuss about vaccines, of course, but before I even discuss vaccines on how it works, I would like to shift first on mutation again. We know that variants of concern do not happen to be just a variant of concern. We have what we call a variant of interest first, and then you have a variant of concern, and then later on a variant of high consequence, which I will be discussing in detail later. Let's first touch on vaccines because I believe that part two of my topic, relevant to this topic this afternoon, where we are now, would be the relationship between the variants of concern and the vaccines that we have. Our vaccines, are considered as foreign substances by our body. And so when we are given a vaccine, that is considered an antigen, and that has to be recognized by our body as a foreign substance. And our body now develops antibodies, so we will be able to have that protection against any form of illness. We also know that there are already certain diseases, infectious diseases that already has their own responses to the illness, meaning to say there are already known vaccines. So, for example, measles for children, and we all had our measles shot when we were still young. We know that the measles is considered as your antigen. And so, because of the development of your vaccine, then you develop already an antibody to it. So, similarly with flu, including chickenpox, including our rabies, tetanus, and even human papilloma virus for cervical cancer among women. So, for COVID, you know that this is the most recent one that we have in during our time, and we understand that the COVID vaccines are very new. That's why there are a lot of agam-agam with this, no? At naiintindihan natin yan every day, mostly Monday to Friday. I give a briefer or a reporting on how our vaccines are currently in Metro Cebu, here composed of the various highly urbanized cities. And I give them updates on how the vaccines are, the response, and even the hesitancies that we have, which we will also discuss later, touching on it later. So there are quite an array of vaccines already in the market. We know that at the beginning of the COVID-19 pandemic last year, we remember that when it happened sometime in January already, that there were already talks about vaccines. And of course, there are different platforms in the development of the vaccines. We have the inactivated form, we have the weakened form of the virus, we even have nucleic acids, viral vectors, and even protein-based, which are what we will be discussing this afternoon, this day. So here in your screen, you will find that the various platforms or technologies that are being developed for COVID-19. And the most common, as you can see, would be what we have today in the Philippines. We know also that when we discuss about vaccines, we also talk about the fact that these are not yet FDA approved. We only have an emergency use authorization for the vaccines. As such, this cannot be sold in the market. When you have already your FDA approval, then there is a certificate of product registration. And when it is already there, then we know that we can individually purchase or procure our own vaccines. To date, we only have EUAs for all the vaccines. There are 8 of them that has an EUA here in the Philippines. And these are the vaccines that we are using except for 2, the Bharat BioNTech and of course Novavax. These are not yet in our country, but I know that they have already an existing EUA for this. Now, we know that the most common, of course, is your inactivated form of vaccine that we have, and it can actually be, exemplified by what we have currently. And there are 2 types. We have Sinovac and Sinopharm. Sinopharm, 1 million doses was given to us. It was a donation last week from the Chinese Republic, Republic of China. And we received 1 million doses for that. And I believe it was specifically to be given to a specific group of individuals. And we have Sinovac. The most number of vaccines that we have here in the Philippines currently is Sinovac. And it is inactivated. So you know that you have a killed pathogen that cannot actually replicate itself. So there is no worry when people would start talking that when you're given the vaccine, that means that you will also have you're given the COVID virus itself. No, it's not so. And we always explain that to the people, especially to the lay people. Another form of vaccine, and all three of these are actually here in the Philippines, we have the non-replicating viral vector. So another virus that cannot copy itself actually carries the pathogens genes. And we know that for these three, Gamaleya, AstraZeneca, and Janssen, they use the non-replicating viral vector. And what is their carrier here? That is their cousin, adenovirus. So alam natin na hindi mismo ang coronavirus ang ginagamit dito, but the carrier is an adenovirus, which is almost similar in, in terms of genetic material to that of coronavirus. You also know that Gamaleya or Sputnik has two components, component 1 and component 2. Now, going back to Sinopharm and Sinovac, these are two doses at intervals of 21 to 28 days. So the same with Gamaleya, that would be 28 days. AstraZeneca also has an interval of 28 days. And of course, the only one that is a single dose would be your Janssen or your Johnson & Johnson. Now, we also have our RNA-based vaccines, and that would be Pfizer and Moderna. So most currently, we had Moderna also given to us as a donation from the COVAX facility. And the 3 million doses coming from the US was coursed through the COVAX facility. For both Pfizer and Moderna, these are the latest in terms of development of vaccines in technology. So people sometimes, make a joke that they become a zombie because of this. There is no truth to that, of course. And we know that the US and Europe and even Israel use Pfizer and, of course, Moderna. Now, we also have what we call Novavax. This is the one that I was saying that is about to come also to be arriving soon, very soon, I hope. So this is made from the protein subunit. Now, accordingly, you would find that for all of these different platforms of vaccines, that there are pros and cons of this. We know that in terms of logistics, Pfizer would be the most difficult, diba? Because you need an ultra low freezer here. You need a temperature of at least minus 70 to minus 80 degrees centigrade. But the rest can actually be accommodated 2 to 8 degrees centigrade. Of course, Gamaleya also has a very stringent, temperature in terms of logistics. However, we know also that the government has really, planned this vaccination program somehow, maybe not perfect, but the system is already in place, and we know where the ultra low freezers are. We even have logistics companies that are carrying these vaccines should they be brought to the provinces. But of course, to those that are really far off, where it will be difficult logistically when it becomes a nightmare, then we do not actually release Pfizer to them or even Gamaleya. Currently, I think, let me see if I have it here later. I'll show that data on where we are in terms of vaccination. So there are two things or two terms that I would want to share with you this afternoon because this is very important, especially the next one. But we'll start with immunogenicity. You know that this is actually the ability of the vaccine to elicit a measurable immune response, meaning to say our body is measured in terms of how would I put it? We have actually in our bodies they have built-in capacities to be able to tide over an exposure to any offending microorganism or a virus for that matter. And so we have what we call the T cells, and we also have the B cells. It is the T cells that are considered to be memory cells. They remember if you have been exposed to an offending microorganism or a virus, and it is your B cells that produce the antibodies. And the antibodies are the ones that will fight off any exposure or re-exposure to an offending microorganism. And so when you have these antibodies, at a certain given point in time, you know that when you are vaccinated, that you develop these antibodies. And given time, when you have, an exposure, this will be the ones that will fight off whatever microorganism or virus you are exposed to. And for this topic, that would be your coronavirus. Now, this one is what I call the reactogenicity. I like this, to be more focused because, again, I think I will be sharing a slide on adverse events later. So we know that this is a subset of reactions that can occur after an individual would receive a vaccine. And these are actually physical manifestations of an inflammatory response. We know that any foreign substance or any intrusion to the normal status of our body, there is a subset of reactions. So for example, kung saan ka tinurukan ng iyong karayom para pagdala sa iyong bakuna, you will develop some form of pain. We also know that you can develop also fever, chills, headaches, no? So all of this actually is because the body has to react somehow to and to something that is not considered normal by your body. And so there are two things that will happen here. One, people may ask na, if I do not manifest anything, like even pain at the site of the injection, does it mean that the vaccine is not effective anymore? The answer there, of course, is no. Because each individual is created differently. Hindi po tayo lahat will have a similar reaction to a given circumstance. Di po ba? Alam naman natin yan. And so the body, because, has to be, the body now is stimulated, or you have what we call inflammatory markers that will be stimulated. And so there will be the production of either your interleukins, even your leukotrienes, cytokines, and this can actually cause or, result into the presentation of local symptoms. That is why in the adverse events, when we talk about adverse events, we graph them, or we group them into two. You have the minor and you have the serious adverse events. And most of the adverse events that can come, or that is because of the reactogenicity of your body, a reaction of your body to the vaccine. You know that most people would complain pain on the injection site, maybe fever, body malaise, headache, okay? And sometimes there are individuals that will even complain that their blood pressure is going higher, or maybe there are some who would even say that they feel so weak, nauseated, and so these are some of the adverse events that we currently experience and are being reported. So sharing with you our adverse event following immunization surveillance for COVID-19 here in Region 7. So as of August 24, for example, at 5 o'clock in the afternoon, of the total 1 million given doses for the first vaccine, you will find that there are 5,120 reports in the VigiFlow for minor adverse events. And so all of these minor adverse events are mostly yung sinasabi ko nga kanina, masakit ang ulo, lagnat, pananamlay ng katawan, okay? Sakit ng kasukasuan, minsan parang nasusuka, naduduwal, o kaya naman nahihilo, o kaya naman chills, no? So that is the most common na nakikita natin. And of this, 53 is serious. I always say this whenever I discuss adverse events, because I believe that we need to be transparent to our people. It is only with being transparent, by guiding them, giving them the correct information, and understanding of what they are going through during, before, and after vaccinations, that they will be more willing to be vaccinated. So, the serious adverse events, as you can see, there are 53 that is reported in the VigiFlow. There is a VigiFlow that is actually a system wherein you have to input, you have to report to your vaccination site or your center any adverse event, any reactogenicities that you develop. Okay, that is one way we are able to monitor if there are things or there are people or patients that we need to follow through. And out of the 53 that are considered serious in the adverse events, our RAFIC, we call that the RAFIC, the Regional Adverse Events Following Immunization Committee, we actually discuss them. So we retrieve all the data, all the medical charts, and then we go over them one by one. Here in Central Visayas, especially in Region 7, there are several experts or specialists, because I always say this, there are no experts right now in COVID. All of us are learning from this. But there are specialists, like for example, our pulmonologist, we have also a cardiologist, endoc, HEMA, of course, infectious disease, and nephro included in our adverse events committee. And there's an epi there and a pathologist, me. I sit in that committee. So we have a schedule weekly, almost weekly, whereby we discuss these adverse events, particularly focusing on the serious adverse events. There are two things that can happen in a serious adverse event. One, that you get admitted and hospitalized. Another one, you may die from it. But so far, as I shared, there were 12 serious adverse events that we just finished tackling last week. And we are going to discuss another 12 today after after sharing my lecture with you, wherein we have to go over, see, and try to analyze the data for each individual case that is in the serious adverse events. And there is a charting there whereby we need to be able to determine if there is a causality in terms of the vaccine and the serious adverse event that an individual is or went through. Classic example, for example, a post-vaccinated person died. Okay, now are you going to link that to the vaccine? Is the death really directly related to the death, or is there are there other factors that could have caused the demise of that particular individual? Of the 12 serious adverse events that we have finished, we have seen not one that is directly linked to the vaccine. Out of the 12, 5 were alive. Okay, they were admitted, but they are alive, and 7 were actually dead. Now, of all of this, we have found one common denominator for those that died. Okay, there is actually a pre-existing condition already, meaning to say there was already hypertension to start with, there were comorbidities that were present, and for 3 of these, it was sudden cardiac death. There was one for myocardial infarction. Another one was subarachnoid hemorrhage. Okay, so you see, there is no direct link. There was even one case that we conducted an autopsy on. The only way we can really definitely find whether there is a direct causality would be to conduct an autopsy. But we also know that people would not want to be autopsied, especially nowadays. The relatives would shy away from an autopsy. So here in the second dose, out of 750,340 vaccinated, there were 981 reported minor adverse events, and 14 are serious adverse events. So this one, we are going to dissect this in the coming days, so we would really be able to establish causality of this. So far, what I'm saying is there is no direct causality or direct linkage between the death of an individual to that from the vaccination. What is sad, though, is this. People tend to blame the vaccine if a person has been post-vaccinated and namatay yung ating pinakunahan. Dapat nating tandaan, and this is what I wanna, relate to everybody. We need to be able to investigate properly instead of just posting social media, instead of blaming the vaccine for it. That is why in our education for vaccine, for our campaign, there are 2 things that we need to understand. One, we need to encourage the vaccinee to reveal their medical histories. Number 2, to be mindful of how their bodies respond to the vaccine. Huwag nating ipagbaliwala. Kunyari, nabakunahan ka, and then ngayon ay alam naman natin na hypertensive ka. Na naramdaman mo na parang sumisikip yung dibdib mo pagdating mo ng bahay, huwag mo ipagbaliwala. Pumunta ka, kumonsulta ka, because you need to be seen by your doctor or in the vaccination center. Kunyari, ikaw naman ay known na hypertensive, alam mo galing ka nagbakuna, imbis naman na ikaw ay magliwaliw at uminom, makipag-inuman sa iyong mga kasamahan, huwag muna kasi bagong bakuna ka. O kaya naman ikaw ay asthmatic, non-asthmatic ikaw. I-reveal mo yan during the history taking and in the medical clearances that you will have to go through. Huwag mong itago yan because that would really help us evaluate whether you should be given the vaccine at that particular time or ipagpapaliban natin yan. Now, for those also, for the vaccinating team, isa din naman yan lagi kong sinasabi. In the vaccination team naman, be meticulous in what you are doing. Huwag mong ibaliwala yung pagkuha ng vital signs, pag-interview kung hindi pa siya na-interview, and be meticulous in the note-taking. Kailangan ilista natin whatever we write down that serves as a document. Huwag natin ibaliwala na dahil babakunahan siya, in good health naman siya, wala naman siyang sinasabi na meron siyang comorbidities, ay ibabaliwala na natin kahit na vital signs man lang, post-vaccination monitoring. So yan po ang gusto kong iparating in our discussion this afternoon. Sharing with you a data from our private hospitals. We are very fortunate here in Region 7, particularly in the Metro Cebu or in One Cebu, no? Na meron kaming tinatawag na Project Balik Buhay. Ito yung aming private sector na kaakibat namin with the government, with what we are doing here, not just in the COVID response, but also in the vaccination. So meron tayong collated data from all the hospitals here in Cebu. Makikita natin for all the private hospitals in Cebu as of August 23 kasi daily nagsasubmit sila sa atin ng mga reports. So, month to date, August 1 to 23, mapapansin natin, these are the total number of deaths. So, 275, i-add natin si 35 plus 18. Yan yung total deaths natin. And of this, mapapansin natin, 84% of those that are namatay sa ating mga private hospitals covering the period of August 1 to 23, 84% are unvaccinated. 5% partially vaccinated and 11% fully vaccinated. Bakit ito kailangan nating ilabas? Bakit kailangan i-share natin ito sa public? Primarily because our focus is not on the small percentage that are vaccinated that succumb to COVID or to death, but rather our focus should be on the bigger portion of the pie, that is 84% of those that died, that left us in this earth, are actually unvaccinated. So ano pong ibig sabihin nito? That vaccines work, that vaccines can save our lives, that vaccines are safe. Yan lang po ang ating pinaka-ultimate goal when we want to share with people on our vaccination program. And I am a believer of this because I know that when we get vaccinated, it's not 100% that you will not get COVID again. I will discuss that in the breakthrough later. So we know also that vaccination, the ultimate goal is actually for us to reach herd immunity. Sabi nga nila, mukhang malabo daw na marating mo ang 70% of your eligible population na magkaroon ka ng herd immunity, kaya pinapalitan na lang nila yan ng herd protection. Yan yung mga palagi nating naririnig ngayon. But I would still want to go into a herd immunity. Alam naman natin, dalawang paraan yan for us to be able to acquire this, either by exposing everybody to COVID or through immunization. If we are going to go for the natural infection, exposing everybody to COVID, we know that the mortality rates will be very, very high because we have the vulnerable sectors. So according to the WHO, and this is how we do it, that your vaccine protects you as a person. You as a person has that responsibility to become vaccinated because when you get that vaccine and you get that protection, in return, you are going to give an indirect protection to the people around you who cannot be vaccinated. And who are these individuals who cannot be vaccinated? Children, 18 and below, or adults who may have a contraindication to the vaccine and who are contraindicated to the vaccine. There is only one absolute contraindication to vaccination, and that would be when you have a history of allergic reaction to a component of the vaccine, or when you develop an anaphylactic reaction to the vaccine. That means that can maybe a contraindication to your vaccination. So when you have that, but everybody else is vaccinated, you know that you confer indirectly in immunity to the people around you. Among children, this is from the PPS, okay, from the Philippine Pediatric Society, as shared in the website of our DOH, okay, of our DOH website. They call that the cocoon strategy. You protect the younger population by giving vaccine first to the adult and the vulnerable sectors. So palagi yan tinatanong ako, bakit hindi pa pwedeng bakunahan ang 12 to 17? Alam naman natin sa Amerika, binigyan na, no, meron na yatang approval ang Pfizer to be given or to be used among 12 to 17 years of age. But we have to understand that here in the Philippines, we have also issues of supply and demand. Hindi lang naman tayo ang nangangailangan ng bakuna, buong mundo ito. So in terms of supply, kulang po siya. At ilang millions din naman ang kakailanganin natin idagdag sa ating previous, na-compute na for the vulnerable sector. The better way right now would be to vaccinate all the adult and vulnerable sectors so that in return, we are going to protect our children or the younger population. By doing that, there is one word in Bisaya that I have learned and I have embraced it as my own. I use that word, pagpakabana. Kasi pag sinabi mong nagpakabana ka, you really care, not just for yourself, but you care about the people around you. You care about your community. You care about your country. So when you do that, you do your share. And what does that share mean? It means you have yourself protected by getting vaccinated. Now, sharing with you only our data here in Region 7 because we do this daily. So by the time you get to see this is as of August 24. All right, so you see that daily we do our tallies, we do our own computations of how many were given the first dose, how many were given the second dose, what vaccines were given, and which provinces are this. And so we are able to compute our consumption, including our compliance rates. Here for Metro Cebu, again, this is one data that we always, share for our Cebu vaccination statistics because we have what we call a Visayas Vaccine Operations Center. Gusto ko nang palitan yan, gawin na lang ng Metro Cebu Vaccination Center, no? Kasi halos heto lang naman yung aming mga dinidiscuss sila, no? So makikita natin that we have given already 1 million doses, no? 1.288652 doses already to Metro Cebu. And our eligible population that we have seen is 1.7 million. We have master listed almost 1.6 million because we have a weekly meeting and a daily reporting for all the Metro Cebu that are involved here. When you look at Metro Cebu, it means that means that Cebu City, Mandaue, Lapu-Lapu, Talisay, Naga, Consolacion, and Minglanilla. And here, you get to see here that in this form here, these are the fully vaccinated in terms of percentage of their population, and these are the single doses that were given. Our target, actually, God willing, with all the supplies that we will be receiving from the national government, would be to vaccinate everybody in our eligible population at least by November. Para lagi nga paulit-ulit, sabi ko, we'll have a happy Merry Christmas, everyone. Okay? So now, let's go to variants of concern. Because apparently, kasama sa ating dapat intindihin, mahalaga ba ang magpabakuna, lalong-lalo na meron na tayong variants of concern. Ngayon na Delta ang pinakalaganap or not really pinakalaganap, but the one that is catching the eye of everybody worldwide, ang tanong ay, effective pa ba ang bakuna natin na meron tayo against the Delta variant? Ang sagot ko po dyan, oo. Kasi alam naman natin na nung dinevelop yung mga vaccines natin, we understand that the original SARS-CoV-2 was the target of that vaccines. But taking into account also that our manufacturers or developers would have to consider also that because RNA viruses mutate, RNA viruses are unstable, so mutations of concern will always be there. Just like our flu vaccines, remember? yearly, we have different strains included in the various flu vaccines that we have. And so that is also happening with our COVID vaccines. Lagi yan, sabi ko nga, I liken it to when bumili ka ng payong. Ang payong na binili mo ay napakaganda para lang naman siya sa araw, no? Para lang hindi ka mangitim at hindi masira yung kutis mo. Biglang umulan, pero yung payong na binili mo ay para lang talaga sa sunshine or kaya sa hot day at hindi naman para sa ulan. Biglang umulan. The payong that you are using can still protect you somehow from the rain that will be pouring, while you are outside. Okay? So it might not give you the full protection because there is a change now in the climate or in the environment that your umbrella is made for. You still know that you get some protection. That is how I would explain the current vaccines that we have, that currently our vaccines, their efficacies may lower in terms of percentage and their effectiveness, but there will still be some form of protection. We also understand that our vaccines, will need to be 2 doses, except for Janssen, which is a single dose. So if you get only the first dose and you defer your second dose because you do not want to be vaccinated for the second dose, you know that you are only conferred 50% of that protection. We also understand that our vaccines do not prevent us from getting COVID again. Neither will it prevent us from transmitting the virus to another individual. But what we are assured of is our vaccines can help prevent us from developing the severe form of COVID. So our variants of concern, we know that they have changed the names already to the WHO label. So meron na tayong alpha, beta, gamma, delta, so on and so forth. Pero heto yung Pango lineage nila, B.1.17, B.1351, at saka meron naman tayong sa GSAID na lineage, no? And of course, the country of origin where these are coming from. I know that there was quite some noise, no, with this theta because sabi nga nila, itong P.3 nito, nagsimula talaga ito dito sa amin, no, dito sa Cebu. And I'm sure that everybody knows that initially, they even named this a Central Visayas variant at tayo po ay pumalag dyan. Kasi nga naman, lahat pangalan ng kanilang countries, hindi naman country of Cebu ito, no? Kaya tatawagin siyang Central Visayas variant. So pinalitan nila, ginawa nilang P.3 and then theta. But good news, accordingly, even sa WHO, tinanggal nila ang theta as a variant of concern. Hindi na siya variant of concern, kundi it is an alert for monitoring purposes only. So ibig sabihin noon na hindi naman talaga dapat nakalista na dito sa variant of concern. Heto si theta. What we are concerned now would be your delta, which originated from India, B.1.617.2. So, hetong ating pinag-uusapan na variants, sabi ko nga kanina, pangalan ay interest, concern, and high consequence. Ano ang pagkakaiba? At bakit nga ba yan sila nagiging concern natin? Una, meron akong tinawag kanina na alert for monitoring, like yung ating P.3 or yung theta natin. Ibig sabihin, meron siyang mga mutations with potential clinical significance, but it is something that you need to monitor, but it doesn't mean that it is of interest. Ano ba ang mga criterion na ginagamit nila for you to be able to say, this one is a variant of interest, this one is concern, this one is of high consequence. Tinitingnan po nila, heto silang lahat. Transmissibility, virulence, detection, immune escape, and treatment. Ibig pong sabihin yan, if there is a variant of interest, meaning to say, there are some mutations with potential clinical significance in the genetic sequence of SARS-CoV-2 happening in a particular locality. But it is something that, kulang ang data, whether it is highly transmissible, o kaya naman mas severe ang kanyang form of disease. Kung kulang ang data, pero binabantayan siya, dahil may tsansa na pwede siyang magkaroon ng mga effect dito sa kanila, then that will be turned or termed as variant of interest. Pero kung meron na tayong datos na nakuha, that will help us determine and check on whether is it highly transmissible compared to the original SARS-CoV-2. Do we have data on that? Is it more severe? That is why it is highly virulent. Is it going to have an impact on the antibodies or in the vaccination programs that we are going through? Then it becomes a variant of concern, which is your Delta variant. Delta variant is already considered to be a VOC kasi alam na natin na in terms of transmissibility, if the original SARS-CoV-2 can infect one infected person can infect another person, 1 to 1.5 individuals, then for Delta variants, this can actually increase from one infected person infecting 8 to 10 more individuals. That is how highly transmissible Delta variant is. And we have seen this happen in countries where Delta is the predominant variant in a particular locality. It is even said that Delta variant can actually be compared to chickenpox in terms of transmissibility, meaning to say 8 to 10 more individuals can get the disease when you expose that person to one who is infected with chickenpox. And that is what Delta variant is all about. And we have seen that here in our locality. We do not even see, you see, as early as July, when we had our third surge of cases sometime in June. I was monitoring that, being member of the COVID task force here. I have been with the COVID task force, and now I am also part of the vaccine task force. Every time we see a rise in the number of cases, I would always look at the cycle threshold because I'm a pathologist, and so I look at the molecular laboratories here, and so I would always look at those CT values, the cycle threshold values, because we know that that is inversely proportional to the infectiousness. The lower the value is, the higher the viral load, and the higher the viral load correspondingly, then it is more transmissible. Okay, so and the reverse is true. I was looking at our data, and I was already informing our COVID core task force group that I believe we do have a Delta variant already, even if it is not yet confirmed by biosurveillance. You know that the challenges of our Philippine Genomic Center is also very huge, being the only one conducting biosurveillance or genomic sequencing. So mahirap din sa kanila yan. And you receive how many thousands of samples for testing, you can only test so much, okay? And it is also very expensive, costly to be running, this genetic sequencing. And so I was already telling everybody that I was reviewing that, and I was saying, we expect to have more number of cases, and should we send our samples to PGC, that we would have a Delta variant already. And true enough, we did. And another thing that I said was, it's not really a Delta variant coming from an OFW or an ROF. What we're having is a local or community transmission. So how do you determine whether that is local or community transmission? Of course, we know that there is no history of travel to an area where there are Delta variants, okay? Number two, you know that it is negative for any history of contact to a confirmed Delta variant person. And so when you have this Delta variant right there at the middle of your place, then you know that you are not dealing with a Delta variant coming from outside, but rather there is that great possibility that is a local or community transmission. And so aside from transmissibility, we also understand that there are a lot of deaths now that we have in our hands. It's not really because it would not even be safe to already assume that Delta variant is more virulent than the original SARS-CoV-2 until we have our data on the grounds studied and well, managed for us to really say without any iota of doubt that that is a highly more virulent SARS-CoV-2 that we have. Now, the problem with the Delta variant is, are we going to be affected in terms of our vaccination programs? Will our vaccines be as good as when we had the original SARS-CoV-2 in our midst only? The answer there is yes. There may be some effect because apparently, based on studies outside, that Delta variants do affect the immune escape. So meaning to say, it impacts on the current vaccines. However, as I said, it does not mean that because there is lessening of the effectiveness of the vaccines that we have, that we should not be vaccinated. It is even more important that we need to be vaccinated soonest that we can. Now, when it also impacts detection, meaning to say that our detection kits now for SARS-CoV-2 cannot detect anymore SARS-CoV-2 or the Delta variant or whatever variants there may be. And it can also have an effect on the treatment currently that we are having in managing COVID, then it becomes a variant of high concern or high consequence, sorry. So you see, when we start with a variant of interest, it becomes a concern and it develops or progresses to one of high consequence, then it will impact transmissibility, virulence, detection, immune escape, and treatment. And how are we going to put a stop to all of these developing variants of concern? The only answer that I have for you would be three. One, we need to stop transmission. The more transmissions there are, we give more opportunities and chances to SARS-CoV-2 to mutate, to develop into different forms of variants of interest, concern, and even high consequence. Second, by preventing transmission or putting a stop to the transmission, there are two major events that we need to do. One would be vaccination, and the other would be our community responses. So, before I discuss the community response, then let us go through breakthrough infections. We know and we are receiving reports that vaccinated individuals still get sick. I mentioned a while ago that vaccines prevent us from developing the severe form of illness, but it will not prevent us from getting the disease again, nor prevent us from transmitting it. In the CDC, in their data for the Centers for Disease Control, they have already stated that breakthrough infections are happening already in the States. And considering that they have for their vaccines Pfizer and Moderna. Now, a breakthrough infection is defined as having COVID again 14 days after your last dose, meaning to say you are fully vaccinated. A fully vaccinated person means you get the 2 doses if it is a 2-interval vaccine or a single dose like Johnson and Johnson. So 14 days after you have had your Janssen or Johnson and Johnson or whatever other vaccine that will require 2 doses and you develop COVID 14 days after that, then you can be qualified or, identified as a breakthrough infection. And another requirement is you need to be positive for SARS-CoV-2 with a PCR test using a respiratory sample. NPS, dapat meron tayo nito. So, when you have a confirmation through your SARS-CoV-2 PCR test with a 14-day after your last dose infection, then you can be tagged as a breakthrough infection and your sample should be sent for genomic sequencing because we need to know what variant of concern or interest is happening to you, why you are developing an infection after completing your vaccination. But the next question is, can we really do genomic sequencing for all those breakthrough infections that we have? That's the big question. Considering that we already have a limitation of the capacity of our Philippine Genomics Center. But the most recent news that we have is that a genomic center or a PGC or a WGS, a whole genome center, sequencing center will be placed in SPMC. Congratulations if this will push through. And another one is actually going to be in Iloilo, in Visayas. But we are, of course, lobbying that we will also have one here, right here in Cebu, so that we will be able to help also in determining these genomic sequences, also for biosurveillance purposes. But one other good news is this, that we have been trying to find ways and means by which we can still detect Lambda, because that's another variant of concern that is going to blow to our faces very soon, and Delta and Alpha. And there are now detection kits. There are two companies that are developing these two kits that we can actually use in our molecular laboratories. So we can definitely say if it is Delta, Lambda, or Alpha, or the original SARS-CoV-2 without even sending it for genomic sequencing. I am looking forward for this to be launched very soon, and I have even offered to have it tried here with me in DOH7 CTRL. So congratulations to SPMC. Once maging reality na po at maging dream come true na, magkakaroon tayo ng WGS dyan sa inyo. Okay? So I'm almost down to my last few slides. I would like to repeat that vaccines are highly effective, okay? And of course, wag po tayong dapat matakot magpabakuna. That will always be our, yan yung ating pangsangga ngayon sa kinakaharap natin na pandemic. And of course, when you talk about immunity protection, you develop that 2 weeks after your last dose. So, ito naman papasok. Dapat ba tayong magpa-test ng ating mga antibodies para malaman natin kung gaano kataas ang ating mga protection at hindi ba din dapat gawin yan? Now, as a pathologist, I would always say this, antibodies can be measured and the antibodies can be reflective of what your body is going through from an exposure of something. And so there will come a time that neutralizing antibodies will become routinary also for us to be able to determine the level of antibodies that we have when we are vaccinated. But right now, I think the Centers for Disease Control is not including that in their test protocols. But I know that in the coming weeks or months, that will be something that we can look into. But it has to be the neutralizing antibodies because we want to check on the spike, the spike protein. We're not going to check on other thing, but rather the spike protein. So that's just something to think about, okay? Now, I said a while ago that it's your vaccines that can be your mainstay. That is not the mainstay, actually. But I call it actually a twin or a parallel in the way we're going to address this pandemic. Vaccine on one hand, on another hand, would be your community response, because the community response will always help us, our minimum public health standards. If you are going to say, bakit kaya marami pang breakthrough infections? Bakit kaya dumadami pa yung mga kaso sa Amerika, considering madami-dami na rin silang nabigyan ng bakuna? O kaya naman sa Israel na lang. Kunin natin si Israel. Simply because they removed masking immediately when they saw that they had a lot of their population already vaccinated. And I pray it doesn't happen to us, that even if we reach or achieve the 70% of our population to be vaccinated, the masks will stay with us until such time that COVID is not a pandemic but is an endemic event in our lives. And so, everything is like the cheese. Lahat po yan may butas, pero lahat po yan pag sinunod natin at ginawa natin, hugas kamay, physical distancing, ang ating pagsuot ng tama ng ating mga face masks, ang ating ventilation, mahalaga po ang ventilation because we know that Delta variant particularly is airborne and it lingers in the air for 16 hours. So mas mahalaga, naka-face mask tayo. Pag masama ang pakiramdam, huwag munang pumasok. Mag-isolate muna. Magpa-test kasi mahalaga yon. At magpa-quarantine kung kinakailangan. At kung kasama dyan ang ating vaccine, I am sure there is no way that we will not be able, to end this pandemic and make it happen to become an endemic event in our lives. And so I think that is my sharing of lecture this today sa inyo pong lahat. I hope that you learned from it and magandang araw po sa ating lahat.
Our next speaker, she had her Doctor of Medicine at the West Visayas State University. She is trained in emergency medicine at the UP-PGH. She's a diplomate and a fellow of the Philippine Board of Emergency Medicine and Philippine College of Emergency Medicine, respectively. She is a medical specialist too, vice chair for patient services, QMS, and coordinator for telemedicine at the Department of Emergency Medicine, Southern Philippines Medical Center. She's a medical specialist 3, vice chair and training program director of the Department of Emergency Medicine, Corazon Lacson Montelibano Memorial Medical Hospital, to talk about cryptics, the code breaker, the hacks and updates on resuscitation. Everybody, let us all welcome Dr. Pauline Convocar.
Good day, everyone, wherever you are in the world. Currently tuning in to our postgraduate course. We are broadcasting from Davao, Philippines. Mayong adlaw ka natong tanan. I'll be speaking on hacks and updates on resuscitation or breaking the code. What you see here in the title slide is a form of a code breaker, the cryptics. This is, however, just a work of fiction or a neologism used by Dan Brown in his book, The Da Vinci Code. Next slide. There is, however, a similar tool called the Jefferson Cipher. This one is real. It's a tool using 26 wheels arranged in secret order on a spindle with randomly permutated alphabet around a rim used to decode, decrypt, or encrypt a secret message in antiquity. Next slide. So there is, we can say that we have similar tools today as what we call algorithms or pathways to guide us on how to break our own code of resuscitation. Next slide. With the many hats I'm wearing and as part of my disclosure statement, I am affiliated with the following institutions and organizations. And in relation to the talk, I wish to disclose that I am head of the section of CPR in Manila Doctors Hospital Occupational Safety and Health Committee and liaison officer of the Philippine College of Emergency Medicine Expanded Council on CPR for the Philippine Heart Association. And of course, I'm also part of the organizing group, the Southern Philippines Medical Center for our postgrad. Next slide. So with that, I am declaring that all views I present today are my own and do not reflect official statements from the institutions and organizations I am affiliated with. And the content of my presentation does not violate any proprietary rights. And use of videos and photos are covered by the fair use and no copyright infringement are intended. So purely for academic purposes. Next slide. And I do not have also significant financial or commercial conflicts of interest to disclose. Next. Cardiac arrest continues to be a concern because cardiac arrests can affect everyone at any time, any place, anywhere. So there's no discrimination at all, young and old, those with optimal health and those with chronic diseases, every race, every financial group, it cuts across all demographics. The patient's point of entry in resuscitation may be in the community or in out-of-hospital cardiac arrest, with the stakeholders involving the bystanders and or extending to the EMS providers or in in-hospital cardiac arrests. So we should establish in all of these 3 points of entry systems of care. Next slide. Knowledge, especially that of resuscitation science, is in the public domain and should be in the public domain. It should be free to be shared. Science-based practices are set by specialty societies and councils all over the globe. And as the science is always changing, we need to always be updated to remain relevant and effectively manage our patients' needs for better clinical outcomes. Ever-changing and the need to somehow standardize care across the globe, wherever you are, should be ensured. So the ILCOR, or the International Liaison Committee on Resuscitation, convenes all of these regional councils to update resuscitation science. And with this new data becomes available, new studies organized, and better collaboration of institutions, these lead to new insights as well as clarifications. So I'll be presenting some updates on what's new in the 2020 guidelines and somehow give insights for high performance teams for 2021 and probably beyond. So to understand this better, let us just have a moment, a very quick moment to watch the process behind the ILCOR recommendations. Next slide, video please.
The International Liaison Committee on Resuscitation, or ILCOR, created a collaborative forum for resuscitation councils worldwide to review and publish the science and treatment recommendations that guide the development of publishing consensus on science statements with treatment recommendations. Through a process of evidence evaluation, ILCOR reached consensus on international resuscitation guidelines in 2000 and on science and treatment recommendations in 2005, 2010, and 2015. Going forward, ILCOR will pursue its vision to save more lives globally through resuscitation. Its mission is to promote, disseminate, and advocate international implementation of evidence-informed resuscitation and first aid using transparent evaluation and consensus summary of scientific data. ILCOR uses a group of experts called task forces, ALS, BLS, EIT, First Aid, PLS, and NLS to review the relevant scientific questions from 2005 through 2015 and categorize based on relevance and prioritize these questions based on new science. A PICO is formatted with 4 elements, where P is population, a unique patient group such as in-hospital cardiac arrest patients. I is intervention and includes the main intervention or prognostic factor or exposure. C is the comparator group, such as those who received standard therapy. And O is outcome, that is deemed important and relevant. The PICO is then subjected to a process of systematic review, analysis using Grade, and the resulting summary of evidence is sent to the ILCOR task forces to develop and post a consensus on science and treatment recommendation. The Science Advisory Committee overseeing the process has lumped all questions into domains that employ a similar search strategy. ILCOR information specialists are developing publication alerts specific to the domain to enable a domain leader to monitor the resuscitation science literature. When new science is published with potential impact, the domain lead, in collaboration with the relevant task force or forces, will activate evidence evaluation process. A simple PICO is then assigned to an expert systematic reviewer. A complex or mega PICO that consists of 4 to 5 related PICOs, or a very broad PICO with multiple subgroup evaluations, will be assigned to a Knowledge Synthesis Unit, or KSU. The output is the generation of a draft consensus on science. The task forces then review it and develop accompanying treatment recommendations, resulting in a COSTAR. Each updated ILCOR COSTAR is published on the ILCOR website for public review and comments. Dialogue with the broader community is valued. Each systematic review will be published and linked to the COSTAR. To learn more, visit us at www.ilcor.org or email us at ilcor@heart.org.
Next slide.
The International
So there you go. Ang haba ng proseso, hindi lang ganun kadali. So ILCOR, as you notice, this includes now the American Heart Association and the European Resuscitation Council, madami pa sila, recognize the substantial time, effort, and resources required to implement changes to the resuscitation guidelines. And they're also cognizant of the confusion that could be caused by frequent changes to guidelines, which could impair technical and non-technical skill performances and adversely impact patient outcomes. So nevertheless, if new science emerges which presents compelling evidence of benefits or harm, this require prompt action that need to be taken to translate it immediately into clinical practice. So to balance these conflicting priorities, they have decided to maintain a 5-yearly cycle for routine updates to its guidelines and course material. So that's the reason why we only have new guidelines every 5 years. So this particular slide shows the evolution of the chains of survival with every 5 years of updating as the ILCOR convenes with new evidences. So as a trivia, if you look at the first chain of survival, you can see there that the telephone is still a landline. So when you have a patient who's arrested, you need to leave the patient and go to the landline and call. So that is very telling of how the evolution went through. So as it evolved, it now shifted. You remember that it used to be airway breathing circulation. It became circulation, airway, and breathing in 2010 with emphasis on compression before the airway. And now on the 2015 guidelines, they have now dichotomized the chain into out-of-hospital cardiac arrest on your left and in-hospital cardiac arrest on the right, with emphasis that with our patients in the hospital, we have to do surveillance and prevention or monitoring to prevent the deterioration of our patients and worsening under our care. So next slide. So in the 2020 guidelines, you see here that they added a sixth element, and the sixth element is that of recovery. We need to also have a process that we have to reintegrate the patient back to the community and give them pointers and advice to prevent the recurrence of another code. Next slide. This is just another perspective of the chain of survival, now using the lens of that of our stakeholders, beginning from the bystander to our dispatchers and our EMS personnel until they arrive at our healthcare workers in the hospital. Next slide. So the latest guidelines from the American Heart Association were actually only released last October 21 of 2020, so kasagsagan ng COVID. There are several changes as to the inclusion of an algorithm for opioid overdose, updates on maternal cardiac arrests, pediatric cardiac arrests, but this talk will only focus on adult cardiac arrest and Taki and Brady algorithms and the aftercare. Next slide. Arrests, as what I've said, may happen anytime, anywhere, in any place, and we should always be prepared to respond as healthcare providers. If sudden cardiac arrest occurs outside the hospital setting, CPR must begin within 4 to 6 minutes. Otherwise, cells begin to die, and advanced life support should begin within 8 minutes to avoid irreversible brain damage. So in this illustration, you're seeing here 4 potential scenarios where on the first line, the first scenario is that there's no CPR, there's delayed defibrillation, and you can see that there's only 2% of survival for the patient. But if there's early CPR, even if there's delayed defibrillation, there's a chance of 8% of survival. It's a better situation when you have early CPR and early defibrillation on the 2nd minute and in the 7th minute. So you now have 20% of survival. So it's a significant increase when you do early CPR and early defibrillation. And of course, the best scenario is when there's this chain of survival when you have early CPR, you have very early defibrillation, katabi lang niya yung AED, and we have early ACLS and the patient is immediately brought to the hospital. You can see that there is 30% chances of survival. So it really is a telling or a very graphic illustration of the dynamics of early CPR, early defibrillation, and early ACLS. Next. So with that time critical nature of arrests or codes, actually COVID is an additional game changer. So we all knew how it was when we had so many interim guidelines. It unfortunately changed many things and impacted on how we run our codes. And COVID has been compared to like running a marathon, ang haba-haba, but with frequently changing rules. Next. You can see here in this illustration that it's the same feeling as that of having the COVID pandemic hitting us when supposedly we are due to release the guidelines on 2020, but there have been so many interim guidelines. And we needed to also revisit how we do our conduct of our codes and the factors that influence the cardiac arrest incidence and mortality outcomes during the pandemic. So in this wheel, there's just so many factors affecting the incidence and mortality of our patients in the COVID pandemic. Next slide. So since the crisis is very far from over, infections are still soaring globally, and you know that we are currently experiencing another surge in the country, we're constantly reminded on the perception that we are fixing the plane while flying it, and we need to balance patient service and protecting the most vulnerable and valuable resource in this pandemic. It's us, the healthcare workers. Next. So there were also some initial questions. Remember, we once asked how we will be able to ensure our own safety while saving others. You remember that point in time early in the quarter of 2020. Our questions on chest compressions and defibrillations may significantly release aerosols. And of course, if we may put ourselves at risk when we respond. So there was this hesitation to really respond when a patient arrested. So there are also horror stories when healthcare workers really refuse to do CPR anymore. Next. So there's this systematic review that they tried to address this. Yes, they suggested that indeed chest compressions and CPR may potentially generate aerosols. And They suggest also that lay may still consider resuscitation with using hands-only CPR and using public access defibrillation. It was suggested that the lay or the bystander may have the same exposure as that of the patient, so they may do now CPR and AED without additional risk to the provider or to the responder, since they have the same exposure anyway. But it was emphasized that a healthcare worker should always use personal protective equipment for aerosol generating procedures during resuscitation. So it's just, of course, it's common sense that we should protect ourselves. Also, that it was suggested that we may do defibrillation even before dawning, because the chances of you being able to revive that patient may be higher, and you may need not intubate or do aerosol generating procedures furthermore. Next. So also, although there is an international consensus on CPR as an aerosol generating procedure, some guidelines even mention the lack of evidence. That's the reason why all of the recommendations in the previous slide were just suggestions and not strong recommendations, because of that very low uncertainty, of the very high uncertainty, I mean. So that would just put ourselves into the good practice part, and we need to focus just on the risks and benefits of the healthcare workers and that of our patients. Next. That then leads us to what we call our protected code blue. So we had to revise our code blue protocols and call it protected code blue. Next. So even before in SARS-CoV-1, so this protected code blue was in 2017 as a response to the Ebola virus and SARS-CoV-1. We had already identified principles in biohazard preparedness and safety to prevent contamination. And this includes all the red colored fonts. This includes protected code blue protocol in our hospitals, the use of powered air purifier respirators. It's already advocated before. Or if not available, we may do double setup or double masking, double eye protection. That would mean goggle and then face shield perhaps. Double gloves, double gown, double everything. And it was already advocated early that we should not bag or we should not ventilate the patients if we don't have negative pressure, or we may have the risk of just spreading biohazard particles. And it was also already observed that we have to minimize the number of people in the room, and high-risk procedures should be performed by the most experienced person available. So we remember that during the first quarter of the pandemic that it were only the consultants who were supposed to do the airway management, because of such rule that it should be the most experienced person in the room, or the most experienced person in the facility to really do the airway management. Next slide. So it is not something new. Here, moving on to the recommendations of the American Heart Association, actually there's not much change here in the guidelines, except perhaps on the next slide. Yeah. When you call for help, the dictum still is safety first. It remains the same. The first principle is ensuring that you are safe to respond, as we do not want you to be the second victim. The first or the entry point is ensuring scene safety still, checking for responsiveness still, and calling for help immediately and getting that AED and activating the emergency response. In hospital cardiac arrest, we call the call for help a code. Calling for the code team and getting the crash cart or the defibrillator. So BLS is the initial or the start or the initial part of your ACLS. We all start with BLS. Even in the hospital, even in hospital cardiac arrest, we also still need to check ourselves and check for scene safety before proceeding. And the compression to ventilation ratio remained the same. It's 30:2, but there was this emphasis that if there's this uncontrolled environment and you're not safe, then we may do only hands-only CPR. The additional change in the 2020 guidelines is that since this is American Heart Association, they advocated the use of opioid, naloxone for opioid overdose because of the opioid epidemic in the US. Next slide. And next. With the arrival of the second tier of the response with the AED, there's not much change again in this part of the algorithm. Perhaps only with the early connection of the AED so that if it is shockable, we could have immediate intervention. Next slide. So in the Philippines, we have developed our own mnemonic. So this was co-developed by PHA, PSEM, PRC, AHA, and the DepEd. And we've come up with the 5 C's mnemonic so as not to forget on what we should do during basic life support, the 5 C's. The first C is check. First C is checking for 2 things, checking for scene safety and personal safety, and at the same time also checking for responsiveness and breathing. So the first check is for the environmental scan, and the personal safety, you should already don your PPE as of that particular point. If you have not yet done that, you should then do your visual checking only of responsiveness and breathing. So you should not touch the patient. If you have done the donning of your PPE before approaching the patient, then you may touch the patient and check for responsiveness and breathing because you're already within your PPE. So the second C is calling for help. The calling for help is, again, as emphasized, is the calling for the emergency response and to also get the AED. The third C is covering the patient's mouth and nose with a mask or cloth, or if not yet done by the provider in one, then this is where the provider will now cover herself or himself with a face shield and face mask and then proceed with the next steps. The next step is with the PPE on, then you may touch the patient, check for the patient's pulse. If there's no pulse, patient is not breathing normally, then you may proceed now with compression of the patient's chest. Positioning of the hands interlock on the center of the chest and begin compressing at 30:2. The 2 may be deferred if you don't have a controlled environment. And then doing only hands-only CPR until help arrives. So when help arrives, the second tier of response, you may now connect the patient to the AED. That's the first C, that's the last C, which is connect to the AED or the automated external defibrillator and just follow the voice prompt. So those are now your 5 C's or the 5 mnemonics of BLS in out-of-hospital cardiac arrest. But you may also use these 5 C's in in-hospital cardiac arrest just before your ACLS part. So if there is also a return of spontaneous circulation in the field and there's no evidence of trauma or trauma is not suspected, we may now put our patient in recovery position. Next slide. We probably just skip this slide because these are just critical steps in the sequence of BLS. Next. Here, it is very important to emphasize that arrests are time critical. Just click, please. And cells begin to die without intervention. So we know that resuscitation success decreases by 7 to 10% for every minute lost without intervention. So this is also, again, a very graphic illustration of being urgent in our interventions. For every minute that lapses, there's a 10% decrease in survival, or what we call the downtime. So if the patient arrives in your facility for more than 10 minutes, or the arrest is not witnessed, or you have not, the last known well is not documented, then the chances of survival if the patient arrives in your facility is less than 10%. Next slide. So this becomes probably now the basis for the previously followed out-of-hospital cardiac arrest clinical decision rule of termination of resuscitation, or the UN-10 rule. The UN here stands for unwitnessed arrest, no shockable rhythms, and the 10-minute rule. So maybe the graph before is the reason why they had this before. Unfortunately, these studies that were used for the unwitnessed arrest, non-shockable rhythm, and the 10-minute CPR without ROSC did not really predict death before hospital discharge. So these were just based on cohorts and carry substantial risk of self-fulfilling prophecy bias. So parang binigyan mo na siya ng desisyon na wala na siyang pag-asa. So there is no single clinical factor or decision rule that has been identified as sufficient to terminate resuscitation. So it still remains to the clinician on their clinical examination, their experience, patient's condition, and wishes to inform their decision to terminate the resuscitative efforts. Of course, they should always be communicated to the family of the patient. Next slide. So moving on to ACLS, very busy slide, sorry, but just to emphasize here that there's not much change though in as to the qualities of high qualities of CPR. They remain the same. Probably just to emphasize that still the same: push hard, push fast, avoid hyperventilation, minimizing interruptions, and allowing recoil. Let me just emphasize though that hard here means the depth. So it's stated here that before it used to be 5 to 6 centimeters, but here in the table or in the table in the algorithm, it is now at least 2 inches or 5 centimeters, probably accounting for the depth when you push on the mattress, because the mattress also is deformed. So you have to account for that loss in the mattress when you pump, not unless you have a firm surface where you have your patient or you have a cardiac board, then it should be only 5 to 6 centimeters or 2 to 2.4 inches. The fast here refers to the speed or the rate of your compression. So the rate should be 100 to 120 beats per minute. The avoid hyperventilation, so they've already emphasized here that it should only be 1 every 6 seconds, or if you have in a controlled environment, then it should be 30:2. 30 compressions is to 2 ventilations. Minimizing interruptions means that the pauses should only be 10 seconds maximum. It should never be more than 10 seconds. And the last is allowing recoil, or you allow the chest to return back to its original position to refill the heart and decrease the intrathoracic pressure. So studies have shown that compression, the rate, if you're too fast, this influences also the chest recoil. So if you know, as you know, if you don't have chest recoil, you do not really refill the heart. So we should maintain our compression rate at 100 to 120 beats per minute. Next slide. So on another note, this illustration just shows the effect of interruptions to the systolic BP. When hands are off the chest, you remove your hands off the chest, immediately the systolic BP drops. And we need to prime again, to pump again the heart or compress effectively for good circulation to resume. So in American Heart Association, actually, the recommendation is only to have maximum of 10 seconds hands off the chest. But in ERC, they even recommended shorter interruptions to 5 seconds. So how can this be possible? The hack is in the timing of intervention suggested in high performance team training. So it should be part of your training to do team dynamics in this case. So there are only 2 moments when we are allowed to have our hands off the chest, remember? So when it is time for rhythm check, so it's a scheduled rhythm check every 2 minutes, or when a shock or electrical therapy is indicated. So these are the opportunities where we may cut on our 10-second rule, or we may have our hack. So we may further decrease hands off chest time if we do hovering. So when it's time for rhythm check, somebody who's the neck compressor should already hover his or her hands over the first compressor, so that when the rhythm is checked and it's non-shockable or shockable even, you may now immediately resume compressions while you are charging your defibrillator. The second hack is when you do pre-charging. So even before the rhythm check, 10 seconds before the rhythm check, you will now pre-charge your defibrillator to a defibrillator dose, so that when it is time to deliver the shock, only seconds are wasted for you to deliver the shock. So that again cuts you around 5 seconds of interruption in your hands on chest time. Next slide. Next. So other noteworthy changes in the 2020 guidelines actually includes the timing of your epinephrine. So in epinephrine, it is given as soon as possible in non-shockable rhythm as that on your right-hand side. So as soon as you have read that the rhythm is asystole or pulses electrical activity, epinephrine may immediately be given. And next slide, on the other hand, if the rhythm is shockable, we may now delay the giving of epinephrine to up to 2 shockable rhythms on your left-hand side if you see the electrical bulb image. So that's when you only give your epinephrine after the second reading of your shockable rhythm. However, the timing or the frequency is still the same. You may still give your epinephrine at every 3 to 5 minutes, but you may simplify it further. The guidelines simplified it further to give it at every 4 minutes or coinciding with your every other rhythm check. Another noteworthy update here in this ACLS algorithm in pulses arrest is that of elevation of lidocaine to the level of amiodarone as drug of choice also for refractory VF or pulses beta. Next slide. So again, no slide before this. Okay, so it's interesting to note that the devices in the ACLS, in the 2020 new guidelines, they have not specifically stated that the biphasic and the monophasic electrical therapies for shockable rhythm. So they just stated there that it's recommended that you look at the manufacturer and the recommendation of that specific device. So we suggested that you should also see, it's stated there that it should be manufacturer recommended. You should look at the manual of your device and see if it's for 150 joules or 200 joules, or if it's monophasic, it's 360 joules. So the suggestion is, if you're not sure of what kind of device you have, you look at the dial or the setup of your maximum energy that you can give, and that is your defibrillation dose. So that's one particular note here in this slide. Next. Another thing that's an update is that in the previous algorithms, there's no note as to when you should consider appropriateness or termination of your resuscitation. So if your code has been going on for a long time, so they put there a clause in the 12th shape that if the code is very long, then you may now apprise your families for consideration of potential termination of your resuscitation. Next slide. So these next two slides are now just for the TACI algorithm and the Brady algorithm. And I will just highlight again that in the TACI algorithm, the change here is that of, again, device recommended energy level. So the suggestion is to still memorize the 2015 guidelines energy levels, because we don't have time to fumble and find your manuals during a code. So actually, we have this dictum that you do not meet your defibrillator for the first time during a code. But if that happens, then you should memorize your energy level recommendations for particular dysrhythmias. Next slide. For the Brady algorithm, what is different here is just that of the atropine dose. So the atropine dose is now 1 milligram every 3 to 5 minutes, but still at a maximum of 3 milligrams, and still the same temporizing interventions as that of your pressors of dopamine and epinephrine, and even using your TCP before your definitive TVP or permanent pacemaker insertions. Next slide. So for the post-cardiac arrest care, they've divided this into two phases. The first is the initial phase and the continued management phase. Just to emphasize that the initial phase is the prioritization of your hemodynamic stability, and then the second phase is about the definitive, or what the cause of addressing the cause of the arrest in the first place. And also further, if it's indicated, to initiate now your targeted temperature management. So the care of the patient after ROC requires really close attention to your ABCs, and of course to address the potential cause of the arrest and to prevent the recurrence of another arrest. Next slide. It's important as well in the post-cardiac arrest care that you debrief your team, and this is also for quality management, for opportunities that you may improve on your quality audits, and of course also to uplift the mental health and well-being of your team, because at the end of the day, it is your team that you'll have to work with to have more meaningful and more productive codes in the future. Next slide. So this slide is just about neuroprognostication. So after an arrest and you may have decided to initiate targeted temperature management, and it just answers also the question on when it's best to prognosticate or when it's best to declare the patient brain dead. So for purposes of organ donation, it is important to note that we should not prognosticate immediately after a code, and we should have a system that we may now involve all of our clinicians and our other specialists to have a team to declare brain death for purposes of organ donation. Next slide. Last few slides. So our status of patients are very dynamic. So they may start as arrested or coded, but may go into bradycardia or tachycardia, or the other way around. They may start as bradyarrhythmias or tachyarrhythmias and go into a code. But the principles are also still the same. We need to also entertain that there's ethics behind this, and that there should always be an overarching principle of team dynamics. So we should always talk to each other. It's not just about knowing the algorithms and all the cognates, but also to recognize that there's really this team dynamics that's involved. And next slide, that we have to understand that the outcome of the code is dependent on how we do our communication. If we have clarity of messages, we know the roles and responsibilities of each member, we know our limitations, we share our knowledge, we have constructive criticism or interventions, we know how to summarize and reevaluate, and definitely mutually respect each other. So next slide, we reduce errors and establish return of spontaneous circulation faster if we have this team dynamics or high performance teams. So as what I shared in the previous slides of particular hacks, we need to also inculcate a culture of excellence while maintaining a culture of safety. So actually, we've learned so much about, next slide, the pit crew or the team approach, the prioritization of resources and structured response. So many things have been, the model of pit crew is really emulated by many of the resuscitation science experts. So next slide. Just an example of the pit crew model being used in out-of-hospital cardiac arrest. Look at the, try to imagine when you have this in the field, look at the dynamics of how the personnel are positioned and that of their equipment as well. Next slide. And if this is OCA, this is ICA or in-hospital cardiac arrest. So there are really certain positions that they hold or they maintain in a code, and the rule here is that any member should be able to replace or to take the post of another member in the group. So anybody can be team captain. That's the reason why we have to advocate that all members in ICA should be ACLS providers. So ideally, there should be only 5 members of the code team, but with COVID, we've minimized the number of persons in the code team. It is acceptable if there's no procedures that need to be done to have only 3 or 4 members of the code team inside the resuscitation room. So the team leader is usually also the airway manager or the most senior or the most experienced in the team. So just to show you an illustration of very high performing team, of course, the illustration is that of the pit crew. Next slide. So here you can see a very elaborate illustration of many people, but having very specific, very specialized roles and responsibilities. There are already pre-assigned roles and game plans. And if I may just show you for my last few slides, an example of a pit crew of a highly performing F1 race team. Next slide. Play, please. already, next page. For me, that was actually already amazing, but that was 3 seconds of a pit stop. But here is the current world record holder, the Red Bull team of F1. Just imagine how many seconds it took them to change the 4 tires of an F1 race. At 1.82 seconds, they were able to do all of these things with perfection, with not much wastage. So if you look at the periphery of their playing field, there's not much wastage there, and they maintain the safety of their team, and there's really this culture of perfection. So I will end by saying that hang on, all of our healthcare providers out there, all emergency department staff, nurses, doctors, shout out to everyone in the front lines. Pwede ko tong i-copyright, but we hope that the public and the government do not trust us that much, because we may be expandable, but don't stretch us too far. We also have a breaking point. So itago natin sa pangalang GOMA, also known as Emergency Department. With this, I end my presentation for correspondence. Here are my contact details. Thank you very much for this honor to present to you today.
All right. I know there are lots of mind-boggling questions right now. So to officially open the live panel discussion, let us call on one of the proud products of the Department of Emergency Medicine, Southern Philippines Medical Center, Dr. Enrico Ian L. Deliso. Please, Dr. Deliso, please, you may now enter.
Thank you, Dr. Custodio. Okay, it was indeed a very fruitful morning. Thank you to Dr. Domingo, Dr. Pingoy, Dr. Loreche, and Dr. Convocar for that very informative and lectures for this morning. Our audience have a number of questions. So I'll start with Dr. Loreche. So most of our participants gave question and addressed their questions to Dr. Loreche. They are really concerned about COVID and the vaccines. So a number of questions po, Doc Loreche, are from our participants. They're asking if there is a need to have a booster dose for our vaccination if they're already done with their full dose of the vaccine?
Okay, thank you so much, no, for the first question thrown my way. Definitely, in the coming months, I believe that a booster will be in the offing. But currently, we are still waiting for guidelines on the matter, whether when the booster will come in, will it be of the same platform that you got for your 2 doses, if it is 2 doses, or whether there will be a mixing of vaccines, no? Meaning to say, since personally I got Sinovac for 2 doses, in the coming months, should I be allowed to get a booster dose, and will it still be Sinovac, or will it be in the form of another platform like maybe a messenger RNA or a non-replicating viral vector? So habang ginagawa pa yan at hinihintay natin, I believe we should be more concerned on currently that you have been vaccinated, to make sure that you have your your minimum public health standards always with you.
So there's still no guidelines po, Doc, regarding if you receive a Sinovac, then your booster dose would be another Sinovac or an mRNA one?
Not yet. Currently, we do not have that yet. No, and we are all waiting and watching with what will happen in our counterpart countries like Israel and the US and the Europe, no, on how they are going to go about their booster doses. So, meantime, stay put lang tayo. And also, I believe that we need to vaccinate more rather than to concentrate on giving booster doses for our very few members of our community.
In relation po, Doc, to another doses of vaccines, there's one participant who asked that, is it possible to have another full doses of the vaccine if they go abroad? So they already received the 2 doses here in the Philippines, and they're planning to go abroad, and is it possible that they will receive another full doses of another vaccine?
I've heard, no, like recently a surgeon friend of mine, no, fully vaccinated here in the Philippines, went to the US to join his family, and he was given 2 doses again of a different platform. I think it's Moderna. Now the problem here is we really lack studies, no, we really lack data on the ground whether it will help you to have 2 additional doses. Which is different from what you have, and what would be the time interval. That is really a big issue. But we know for a fact that usually our immune system or immunity or the protection that you get from the vaccine would start to wane off 6 months to 9 months after you are given the complete dose. So we should be expecting that booster doses should be released or given 9 months at least from the time that you were fully vaccinated. So having to have that again, no, in less than that ideal time, to allow your immune system to recover and to be able to develop what it needs to develop to form an immunity or a protection against coronavirus. That is, something that we need data on for us to be able to truly say na mas effective siya at siguradong hindi ka mahahawa ni COVID.
So there is also a possibility po, Doctora, that a yearly COVID vaccine will be administered to the whole population, just like the normal influenza.
That's definite, no? That there will be a yearly booster for COVID, coronavirus or COVID-19 vaccine. But as to whether it will be free from the government and it will be given to us, no, that is something that we need to wait and see. Because definitely, I believe in our daily meetings with the vaccine rollout in the country, that is also being considered already.
One participant din po, Doctora, asked that she already received Astra first dose. However, she needs a tetanus toxoid. So na-defer po yung second dose niya. And now she's having difficulty of getting the second dose. Her question is, until when daw po yung protection that the first dose can provide?
Actually, what we have in our data right now is first dose to be followed ideally for AstraZeneca. That should be 8 weeks from your first dose. Dati kasi sinabi natin that should be 12 to 14 weeks, but we have lowered it to 8 weeks already. So now the question is, how long can you withhold your second dose? You can actually withhold your second dose 3 months to 6 months maximum from your first dose. That will only apply to certain conditions, like yung sinasabi mo na meron ikang tinanggap na toxoid, no? Pero galing din sa ating guidelines, you can actually have your second dose or even your first dose of your COVID-19 vaccine after you're given a different vaccine, like for tetanus or maybe for rabies, no? At least, sinasabi natin, 14 days from your dose of that particular vaccine, provided that you are cleared by your attending doctor.
Another question rin po, again to Dr. Loreche. Previously infected with COVID and then reinfected again, what would be the severity? Would it be milder or more severe the second time around?
That's kind of difficult to answer, but definitely we have a definition for reinfection. We always call it a reinfection by epidemiological standards, that you had your second infection for COVID confirmed, ha, hindi lang yung haka-haka, at least 3 months from the time that you had your first infection for COVID. Now, as to whether it becomes a milder form, a moderate, or a more severe one, that will now depend on your immune status. Kasi syempre, remember, you had your exposure, your body reacts to it, so you develop antibodies to it. But remember that if you are a young person, a young adult whose immune system is already pumped up, and you have, the nutritional status and everything else that you have working for you, then in all probability, you might, have a milder form compared to a more severe one.
So, but I think it all boils down pa rin po to the minimum public prevention. So we should still wear our mask and all those stuff.
That's correct. And that is already the messaging that we would want to address to our people, no? Kasi minsan, those in our data here in Central Visayas, especially in Metro Cebu, we found out that those that get reinfection after, or we call that the breakthrough infections after their full dose, of their vaccine, are actually because, the young people, they feel like they're already protected, so they go about their regular activities minus the minimum public health standards. So yan dapat ang isa sa ating mga key messaging when we endorse our vaccinations.
Thank you, Dr. Loreche. I'll now have some questions to Dr. Domingo po for PhilHealth. One participant po, Doc, asked about she's already an accredited healthcare provider for PhilHealth. Now, with the implementation of the universal healthcare, would she need to be to have another reaccreditation for the universal healthcare as a primary care physician?
No, you don't need to get accredited. Yung dati mo accreditation number, that will suffice.
So just continue with it na lang
Yes.
po. Doc, one question po. What would be the impact of the COVID-19 pandemic in terms of the future, in the implementation of the universal healthcare, in terms of knowing that the PhilHealth is still the financing body for the implementation of the UHC? Would it have a negative impact po or what, or something?
Well, in terms of our funds, right now, our funds are intact. Malaki ang nailalabas natin in terms of benefits because of this COVID. Actually, if you look at our claims data, the COVID is around 15% of the total claims that we receive. So it's big, but it's not that big. But the benefit rates are higher than the usual rates that we have in our all case rates. So as to the impact, well, maybe it might be felt several years down the road because PhilHealth has a reserve fund right now around 140 billion. So nakukusyon namin yung impact ng pandemic na ito. And collections, surprisingly, is still coming in. I mean, robust, no? Because we expected with all the economic difficulties of our people right now, hindi na makakabayad sa premiums. But when we just looked at the data, still we're getting high collection efficiency except for our OFW members because talaga malaking impact sa kanila. Marami sa kanila repatriate. So we're okay. Okay pa naman yung ano natin. It might affect several years from now, but right now we're okay.
We all know, Doc, that COVID will not be here forever in God's grace. And as of the moment, the PhilHealth coverage for COVID is really broad in terms from coming from the testing up to even the isolation. Once this COVID will become an endemic in the future, would the coverage of PhilHealth for COVID would still be the same?
We base our rates on existing costings of the disease, no? At the start, talagang until now, mataas ang COVID benefit packages natin because mahal ngayon paano ng COVID, no? Lahat ng PPEs kailangan, lahat ng maraming factors that increases the cost of a COVID benefit package. But we don't know. We constantly review naman our benefit package. We don't know down the line. It might go down because the factors that contribute to it might lessen. Baka bumaba yung mga market cost. Hindi po natin alam. So we review constantly our benefit package rates. So yun.
Another question po, Doc. In relation to PhilHealth and the universal healthcare, the law, in the implementation po of the UHC, knowing that the referral network would be of big importance in the universal healthcare, would PhilHealth cover or include the pre-hospital care providers in its coverage po? Like our EMS group and ambulance providers po?
Okay, under universal healthcare kasi we will be shifting our provider payment mechanism. Right now we are all case rate, no? It will be shifted into DRGs and global budget payment. In other words, we will be based on the universal healthcare law and its provisions, we will be contracting already with a whole network of providers. So, and then we will be paying through global budget. So, lahat na mapapasok doon sa global budget na yon. So, as to your question, it will really depend at that time on the contracting terms between us and the healthcare provider network. So, it may be included because global budget na tayo.
Thank you po, Doc. My next question would be for Dr. Pingoy. So a number of participants are also, especially doctors, are very interested in terms of the topic on financial stability because knowing that this topic was never included in any medical schools and even in undergraduate courses po. What would be the best passive income, sir, or any business ventures that doctors and other medical professionals, knowing that we are very busy, that would be of great help in terms of financial stability?
Dr. Diliso, mayang buntag og sa tanan. Encompassing lang, no? The best investment or business that you would go into is the business and investment that you understand very well. And sa ngayon, most of the information that we need are very cheap or even free online. So just make sure that you know what you are going into. And there are so many things. Now, the difference between investments and business is you put your money on both, no, business and investment. However, in business, you have to be actively involved. In investment, you invest and you let someone else run the business, and hopefully you get your money back plus some more. Yeah. So it's more of what you understand and what you are comfortable with.
Thank you, sir. Sir, sa lecture niyo po kanina, you've mentioned that we should not incorporate insurance and investment. Now, a number po kasi ng mga insurance products are yung hybrid po ng insurance and investment. Now, for those people na naka-avail po ng ganitong product, is it a smart move to stop that coverage po or to just continue?
Looking at the fine prints below sa contract ninyo, there should be an exit clause. No, I don't know. Depende. Pero as I have said earlier, I'm sorry ha kung naay mga brokers and all. If you combine both, they get a lot of commission right away from the start. 30%. That 30% you will never see again, and it will never grow. So right now there are so many instruments that are very, very easy to come by. You don't need brokers. You can do it yourself. No. So ang term insurance are very cheap, especially as I have mentioned, sa mga working in medical institutions, because my privileges. And once you do that, the rest you invest on your own. You know better than these brokers, or you better know yourself better than these brokers.
So get a separate insurance policy, sir, and then
yes,
invest.
Yes, term lang, term. Ako alang na ha nga advice, but of course you can check around and you can do your thing.
Sir, but do you think, sir, that it is really prudent to teach to be at that financial literacy should be part of the medical curriculum?
I think so. Para ma-force tayo to learn. But if it's not included, it's all available online. And I would say we have cell phones and connectivity. Let's use it as a tool instead of a toy. Na we spend much time sa Facebook and knowing other people's lives and not knowing much of our lives. So,
how about the stock market and Bitcoin? Because a number of doctors now are into the stock market. What would be the things that we should be maging careful ba in terms of doing stocks?
As I mentioned earlier, it is fashionable to discuss about Bitcoins and stock market. You sound very intelligent, especially sa Starbucks. 95% of people, they lose money sa Bitcoin and other, if you don't know what you're doing. The 95, that's their profession. Yung profession natin is being a doctor, being a nurse, sa side, yes, of course you can. But again, if you're not very careful about it, you will lose a lot of money. Naay uban diha nga nagabaligya og saging maruya sa daplin og kanang sudan lang, mas dako pa ilahang kwarta kaysa Bitcoin. But of course, it is fashionable if we talk about Bitcoin. So again, read, learn more before you engage. That's how you lose a lot of money, probably including the shirt that you are wearing. So caveat, beware.
I think, sir, most of the doctors naman are adept in studying.
I hope.
So
I
so
hope.
hopefully everybody will become, aside from being good in terms of the medical practice, we would become more financially literate and in terms of our financial stability.
Yes. 85% across the board. Doctors, engineers, lawyers, and even kung ano-ano. When they retire, they are struggling. It does not mean that we are doctors. We are automatically financially okay when we retire.
We will take note on that, sir, and that very, very good advice from you po. Thank you, sir, to Dr. Rapao, Dr. Convocar, our mentor at SPMC Emed. Doc, I have several questions po coming from the participants.
Unsa ni siya nga nang dili na ko magkuan? Unsa ni siya?
Doc Convocar, my first question po, for those people who are on duty in the front lines, and if they receive po patients as an out of hospital cardiac arrest, and if the first rhythm is non-shockable, how long would that team will proceed with the resuscitation?
Are we talking about COVID or non-COVID?
COVID po. Confirmed COVID.
Confirmed COVID, okay. There's no literature saying really the lengths of time or even to initiate care or not. It's not in the clinical guidelines, but it is in the ethical guidelines. So there are two different things. In the clinical guidelines, of course, you have to look at it in the context of, do you still have enough resources? Because if you still have enough resources, then it's prudent that you save one life. But if you don't have enough resources, then you have the difficult decision to let go of that one case for the benefit of the many, or the benefit of many others. So it's really a difficult decision, especially for emergency medicine or any facility whatsoever, for that matter, when you have to look at your resources and see that you don't have enough resources, because now it becomes the shift now is to being able to still address the need of one versus the need of many. So it's currently what's happening right now. But with regards to the length of time, there's no one guideline or no one clinical rule to say that it is 15 minutes or 10 minutes. That's why I presented the UN 10 rule, because I wanted to debunk it because it's not true.
Doc, with regards po sa increasing cases ng COVID in the country, do we have already a data of an increase in the number of the trend of the increase in OCA and ICA?
So it's an interesting question, because we don't really have a registry for out-of-hospital cardiac arrest and in-hospital cardiac arrests. We just take note of deaths from COVID or case fatality, and not specifically if it's dichotomized as to OCA or ICA. That will be an interesting study, but it could also mean that people do not get to the hospitals anymore, and they die in their homes or they die en route. So it may be an interesting thing to report if where the death really happened, because oftentimes they arrive at the facility already dying. So it may be probably an interesting area to research on in the Philippines.
I think, Doc, that would be a very good research topic for the residents. Doc, in terms of the advocacy of PHA and to make the Philippines as CPR ready, are we there yet? How far are we, or how near are we to make the Philippines CPR ready?
That's a Miss Universe question, and probably a Miss Universe answer. Malayo pa, pero malayo na rin. So we're not yet there yet. We're not yet there, but we're moving towards getting there. So I think there are already seeds planted, but of course, it takes a lot more and a lot more resources and collaboration perhaps to really get there. By getting there, it means lang at least one family member who's a provider in the home. So at least one Filipino member in a family who is a BLS provider. So yun lang, ganun lang. So if you have 100 million Filipinos divided by probably a 3 to 5 member in a family, so that would be how many families? And then it just probably mathematically, kaya lang extended families din tayo because most arrests happen at home. So that's the reason why the advocacy is really just to have one family member be a CPR provider.
Doc, do we have already an update on the EMS bill, or are there any laws that mandates the provision of AED in public areas already?
Unfortunately, many things really happened because of COVID. So that's one thing that did not really move far. We had the farthest as we reached the farthest as to the second reading, even scheduling for a third reading supposedly, but unfortunately, mas maraming nauna ng mga laws na nauna. So therefore, it's there. We have already parang integrated all the other versions, but as to saang level, nauna si EO rather than the EMS law. Kaya nauna muna yung 911 Commission, nauna muna yung ibang mga commissions. I mean the EO's executive orders rather than the law, because it has so many readings still to pass through before it becomes law.
Thank you, Dr. Convocar. One last question po. This is addressed to Dr. Domingo po. One participant asked po, Doc, what are the possible reasons daw po for a denied claims for COVID?
Denied claims for COVID, for one, there are reasons like lampas, it's more than the 120 days that were given to file a claim. That's actually the topmost reason at the moment, no? Kasi usually it's 60 days, pero during the pandemic, we extended it to 120 days. But unfortunately, marami pa rin hindi nakakasubmit within the 120 days. Therefore, we are asking them to file an MR or an appeal, and the reason why lampas. So that most of the time it's that. Other reasons for denial would be some policy issues that were not yet resolved. For example, policy issues. No, for example, remdesivir. But we're not denying that. What we do is return it to hospital, because as you know, remdesivir now is not yet registered. Wala pa silang CPR in our DOH, no? And there's an issue yet, like WHO says, remdesivir is not included in the standard management of a COVID case. It's all debates, and we're not going to that. We're not a technical agency, no? But we have to follow what the Department of Health puts out as guidelines. And therefore, usually yung denial ng COVID cases because issues also like maybe probable that's still being discussed also now, the false negatives na cases, no? But those were, dati it was causes for denial because it's not within our guidelines. However, ngayon ang ginagawa namin is we return it to the hospital and then i-refile na lang sa amin. So we had several already discussions on these policy issues, and we have resolved it. And therefore, we hope malesen ang denial of COVID claims.
Thank you po, Doc. Again, thank you to all our speakers for your time and your sharing your expertise in this morning's topic. We have still a number of questions in the chat box, but we have limited time. So we'll try to answer all your questions dun sa mga nag-type ng kanilang questions sa chat box. So thank you again. I'll give now the virtual floor to Dr. Custodio.
Thank you, Dr. Ian Deliso, for giving our speakers a not so easy time. And to our speakers, may we present these certificates. We would like to show our gratitude for sharing his or her time and expertise as a resource speaker during the 4th postgraduate course of the Department of Emergency Medicine of the Southern Philippines Medical Center, entitled Embrace the Odds, the Old, the New, and the New Normal, held online via Zoom on the 3rd and 4th of September 2021. Co-signed, Sincerely yours as the course director and Dr. Benedict Edward P. Valdez as the department chairman. This certificates of appreciation is hereby presented to Dr. Shirley Domingo, Dr. Pauline Convocar, Dr. Albert Pingoy, and Dr. Mary Jean P. Loreche. Again, thank you to our resource speakers. All right, that sums up our morning session. See you later on for this afternoon session. We will start at 1 p.m. To those our attendees and participants, you may need not to log out. You just have to stay tuned, but if accidentally logged out, you may use the same link sent to you via your personal emails. See you all this afternoon. Thank you.